From a routine repeat biopsy, after some time, there are decreased chances of detecting a clinically significant prostate cancer by 38 to 60%. They may miss 5 to 6% of clinically significant cancer, but the incidence of biopsy may be reduced by 38%. The same were echoed in PROTECTILE, and the duration for repeat PSA testing was 7 weeks to 4 weeks. So from all this evidence, they recommended with a weak strength that in asymptomatic man with PSA level between 3 to 10 and normal DRE examination, repeat PSA testing should be done before biopsying the patient. Now, very interesting concept has been added, that is extended MRI direct biopsy. We know targeted biopsy, MRI targeted biopsy, and we know systematic biopsy. But then what is extended MRI? So the panel, they found out that multiple perilesional biopsy around the target course, if they are biopsied along with the MRI target course, that can replace systematic or target biopsy in future. However, the clinical data or the clinical trials are not mature to recommend for anything. Just this they brought to the notice. So as far as the biopsy goes, we have level 3 evidence that at least 10 to 12 core biopsy for initial and repeat biopsy patients with which should be done depending on the prostate size. And it should be weighted around lateral aspect and apex to sample the peripheral zone. Then we have a level 2 evidence to suggest that MRI targeted perineal biopsy has a sensitivity of 86%, which is more than 73% of MRI directed transrectal biopsies. Again, we have a level 2 evidence that any image guided technique is not better than the other. That is either cognitive guidance, US or MRI, software, or direct in-bore guidance. So with this evidence, the recommendations say that very strongly, at least 8 systematic biopsies should be done in patients with prostate of 30 cc or less, and 10 to 12 with prostate size of more than 30. More than 12, it's not going to gain more results. Secondly, transperineal biopsy should be preferred. And when MRI shows a suspicion, any image-guided technique it's okay. Then, like one thing which is added in this reporting of prostatic biopsy, like they strongly recommend to report the type of adenocarcinoma, because it has been found that intraductal carcinoma and poorly differentiated adenocarcinoma, they have a very poor biochemical free survival and metastatic free survival. Whereas cribriform pattern has shown in various studies to increase the rate of metastasis, biochemical failure, and death. So they should be reported and specially mentioned in the biopsy reports. Regarding the staging of prostate cancer, so now we have very excellent level 1B evidence to prove that PSMA PET scan is more sensitive as well as specific than CT and bone scan for high risk disease. Still, the recommendation for getting PSMA PET scan in high risk disease is strong, but they still give a word of caution that you should be aware that the outcome data are not available for this modality. Now, one thing which they have added in treatment part is the radiopharmaceutical therapy. Like it's a new therapy delivery, I mean, not routinely performed, not new, but it's not routinely performed. It's delivery of radioactive atoms to tumor associated targets. The mechanism is radiation induced killing of cells. 2 types of nucleides are present. The one who emit beta particles, as for example, lutetium, the one who emit alpha particles, that is radium and actinium. The panel found that lutetium with a very short half-life and lateral spread is very less, so less damage to the surrounding normal tissues is preferred. Then they also mentioned about theranostics, that is the same nucleotide used for diagnostic and therapeutic purpose. However, they specifically pointed out that requirement for using of radiopharmaceutical therapy is a PET scan to assess the targeting of the agent and extent of the cancer. So for treatment, like, I think only one change has been made for surgical treatment of prostate cancer. That is, do not perform nerve sparing surgery when you find that the chances of ipsilateral extracapsular extension are more, based on various pathological parameters. The other changes are related to radiotherapy. I'll be taking that separately when I talk about individual risk groups. Now one thing which they very specifically cleared out in these guidelines is the controversy around which rotates around ADT monotherapy. So like they studied 3 RCTs from early prostate cancer trial program. More than 8,000 men of localized and locally advanced prostate cancer were studied, And they were given oral bicalutamide 150 milligram monotherapy versus placebo following standard of care. That is either radical prostatectomy, radiotherapy, or watchful waiting. So they found that there was no improvement in progression-free survival. In fact, there was trend of worsening overall survival, after which they stopped it compared to placebo. And that is why the guidelines, they strongly recommend that all low-risk asymptomatic patients not eligible for any local treatment should be given only watchful waiting. ADT monotherapy has no role in present scenario. Now, let me come to the treatment based on the risk groups. So for low risk groups, they have some summary of evidence for systematic biopsies. Like in the era of imaging, when we have an MRI, what is the role of systematic biopsies if we want to subject the patient for active surveillance? So there is no standard protocol has been found for systematic biopsy. So they don't recommend that. So what are the recommendations? So if in patient comes to us and the imaging is not done before the biopsy, then they advise to get a confirmatory MRI guided or MRI targeted biopsy done for those cases. For repeat biopsies, it should be done every 3 years up to 10 years. This has been added, although the strength of recommendation is weak, but they strongly recommend that in case of any evidence of progression, that is either PSA or clinical, that is DRE or MRE findings, before starting active treatment, you should get a biopsy repeat again. Again, for radiotherapy, they say that for low risk disease, either low dose brachytherapy is sufficient if the patient is having good urinary function. Now for intermediate disease, the term is already there in NCCN guidelines, but now they have introduced in EAU as well. They define a favorable intermediate risk group. So selected patients of grade group 2, in whom the percentage of pattern 4 is less than 10, that less than 3 cores are positive, and per core less than 50% involvement is there, along with other factors of low risk, that is PSA is less than 10 and clinical it is less than T2A. Those can be observed or active surveillance can be applied on these cases. Well, they strongly recommend that any grade group 3 should be excluded from and they should be treated actively. Again, if in follow-up biopsies you find that the parameters are changing, especially if more than 3 cores are getting positive or more than 50% per core is getting positive, then you should reclassify and reconsider the treatment strategy. Based, again, the radiotherapy has changed based on the changing of group settings. Okay, so I'll move fast. In high-risk localized disease, again, radiotherapy is advised, but then ADT is for 2 to 3 years. And in locally advanced status, again, radiotherapy is advised, but one change they have made is that if the patient is having positive lymph nodes or more than 2 high-risk factors out of TC3, Gleason more than 8 or PSA 40, you should give 2 years of abiraterone therapy. So this has been a strong recommendation in guidelines for this year. So this is probably my last slide. Okay, so now there is very much confusion about the threshold of biochemical recurrence after radical prostatectomy. So previously it was 0.5. Then after invention of ultra-sensitive or introduction of ultra-sensitive PSA, it became 0.2. So in recent guidelines, they say that if the features of low risk of recurrence are there in the histopathology, then whatever amount of nadir PSA is attained, and then you find 2 subsequent rises, you should subject the patient for some form of additional therapy. For metastatic disease, antagonist and orchidectomy should be preferred for hepatic clinical complications like spinal cord completion and bladder arterial obstruction. And for early systematic therapy should be started for M1 metastatic disease. For castrate-resistant prostate cancer, based on our previous slides, which we saw, they have introduced lutetium therapy for after all the treatment therapy for MCRPC have exhausted. You can give lutetium PSMA therapy based on whether the metastases are expressing PSA more than liver. That is, they are highly expressing PSMA, sorry. And that in those cases, you can give lutetium. So to summarize, changes have been made directed at avoiding over-treatment of clinically insignificant prostate cancer. Changes have been made directed at avoiding unnecessary biopsies. Changes have been made to standardize the number of cores, techniques, and reporting of prostatic biopsies. Use of PSMA PET scan in high-risk disease has been defined. And the role of pharmaceutical therapy has been postulated, but not clearly defined. And ADT monotherapy is of no use. That has been clearly stated in the guidelines for this time. The changes have been made in treatment recommendations, mainly nerve sparing RP, role of radiotherapy, and metastatic hormone and sensitivity and hormone sensitive in CRPC. Thank you.
Thank you, Dr. Keval. Any questions from the audience?
Sir, an elderly male with raised PSA and a nodular prostate on DRE, would you go ahead with directly a biopsy, a tissue diagnosis, or an MRI first and then take a?
So I'd like to again clarify that all the slides which I showed previously is for the patient who is having normal DRE examination. So this is for the patient who are picked up by screening in the West. When there is a DRE and there is high suspicion on PSA, you should go for biopsy.
Right. And one, I think, important point from this recommendation is for locally advanced disease, which is probably the kind we see most often in India, high PSAs, T3. So the addition of abiraterone 2 years with ADT, with radiation as standard treatment of choice is something which is very new. And as uro-oncologists and surgeons, probably little worrying because that has become standard of care as according to them.
Thank you, Dr. Keval, for a wonderful presentation. So I'll just comment on two things. So first, to answer Milap's question, I think in today's date, we need to have an MRI prior to biopsy. If
Exactly.
In your slide itself, if you have to label it as a clinically insignificant prostate cancer, it should have an appropriate imaging. So MRI is important for
Yes,
that.
sir.
Secondly, if you are planning to do a biopsy, whether that patient is for biopsy or not depends upon, again, the two factors, PSA density and
MRI.
MRI. So MRI is gone are the days 10 years back when we used to say that it is for high risk, it should be done.
Pre-biopsy MRI.
Yeah, so you have to have MRI in today's date. And even when you're doing biopsy today, systematic biopsies alone are not enough. You have to do targeted biopsy along with that in MRI, whether it's a cognitive targeting or whether it's a fusion biopsy. Secondly, regarding the repeat PSA testing. So you mentioned that between 3 to 10, if PSA is there, whether you need to biopsy or you need to do a repeat PSA testing. So repeat PSA testing should be done in these patients. And what next? What do you expect from that repeat PSA? It decreases the biopsy rate from to 16% in 3 to 10, and also decreases. Also, what happens is that if the PSA is less than 3, if suppose the PSA is 7, 8, whatever, if it comes down to less than 3, these are the rates it is recommended. If it is if it comes down less than 3, if it from 8 it has come down to 7, it does not mean that.
So I skipped that side in hurry because of the finish. Okay. So the guidelines say that it should decrease by 20%. So
then again, there are a lot of things in that. Yeah. If it comes down less than 20%, then it is more towards divine. If it comes down 10 to 20% sort of thing, you are likely to find glycine grade 3+3. Yeah. So if it goes more than 20%, if it changes more than 20%, if you talk about glycine 3 ISP to glycine 7 grade, so if it comes down or it increases more than 20%, the percentage of 7 glycine is going to decrease, because if it comes down, it will probably go towards 6. If it increases, it probably go towards 8.
Yeah. So sir, but this is mostly for grade group 1, not for grade group 2.
So I think we are up with the time for this speaker. So let me invite the next speaker, Dr. Rahul Jain. He'll be speaking on the bladder cancer guidelines in 2022, what has changed.
A very good afternoon to my seniors and all my colleagues. I'll try to work it right this time. So, in this presentation, I'll mainly be concentrating on the European Association of Urology guidelines, the NCCN guidelines, and the AUA guidelines on microhematuria. In between, mostly I'll try to focus on the changes that are related to clinical practice, because it's very difficult to make a presentation where you are just concentrating on the changes from last year or the last 2 years. So the first thing, to talk of bladder cancer and leave out evaluation of microhematuria, for that, what has changed is now AUA has divided every patient presenting with microhematuria into 3 groups: the low risk group, the intermediate risk group, and the high risk group. What has changed is now they don't recommend a complete evaluation, the same kind of evaluation for all the risk groups. So if you have a low risk group, that is, as defined here, So you do a follow-up, right? If you do a follow-up after 6 months, you don't need to do any imaging. And if that follow-up also shows you microhematuria, persisting microhematuria, it automatically transfers into the intermediate risk group and you evaluate further. If that patient has an intermediate risk group, you do an ultrasound, not a CT scan. CT scan is not recommended because it has been seen that in these patients, the yield of cross-sectional imaging is actually very low. And you do a cystoscopy. That can be an office cystoscopy or, according to your institutional policies. And if you have a high-risk group, as was defined, then you do a CT scan and a cystoscopy. And you do a white light cystoscopy. There is no need actually to do the photodynamic techniques because those have been proven in patients who have known bladder cancer. It has not been used in the screening of patients having microhematuria. And there is no role for cytology in these patients except for those who have a negative workup and persistent microhematuria or irritative bloods. Now, if you have a patient with gross hematuria, obviously you do a sonography and a CT IVU as an initial workup. Guidelines say that patients with diagnosed bladder mass do a CT IVU only in selected cases. For example, if you have a mass involving the trigone or if you have a large mass. But in clinical practice, I believe almost all of us, when we have a diagnosed bladder mass, we do a CT scan irrespective of the location. You do a cystoscopy and you do a urine cytology. The change is that, although this is not a recent change, but yes, Paris system has now been widely adopted. We do not follow the older system anymore. The philosophy behind this system was that the authors postulated that low-grade malignancy differentiated by a different pathway, high-grade malignancy differentiated by a different pathway with a different set of mutations. So, even in group which is suspicious for high-grade urothelial carcinoma, you still have 50 to 90% of risk of malignancy. And that was one of the main reasons why this system was adopted. Now, all of us know when to do a TURBT, but when to do a prostatic urethral biopsy. If you have bladder neck tumors, you have presence of carcinoma in situ, you have a positive cytology with negative cystoscopy. In this case, you also do random bladder biopsies, or you have a visible growth or abnormality of the prostatic urethral mucosa. Okay, so coming to the grading, a lot of reports that I keep seeing in general practice, also those patients that are referred to our institutes, pathologists either report this or they report this. What is important to realize is that there is an overlap of pun lump and low grade in grade 1. There is an overlap of high grade and low grade in grade 2. So, the meta-analysis and studies have shown that you get the best prognosis when you use a combination of both of these to predict the recurrence and the progression. So these guidelines recommend that pathologists report bladder biopsy reports as a combination of both of these staging, histopathological grading systems. Now, how to calculate the risk of recurrence and progression. So you have a 2006 EORTC system for predicting, a calculator. You have the Kyoto model, which is for patients who have been treated with BCG. You have the EORTC model, which is again for BCG treated patients. What I personally like the most, although this is for non-BCG treated patients, is the EAU NMIBC 2021 scoring model. Why? I'll show you in my next slide. See, this is the risk group. At the outset, if you look at this table, it appears very daunting and intimidating. Who would remember all of this? It's very confusing. So what they've done is, you go to the app store, download this app, you search for it, and you just, enter the patient details in the video. It's relatively easy to use. And it actually makes a difference because then it gives you a calculation of the risk of progression according to the older system, the newer system, and what is the risk of progression and recurrence at 5 years, 10 years. Is very easy to use. And I use it in almost all cases of, CA bladder that I see. So we have done a TURBT. What next? I'm concentrating only on the changes and important points. So if you have a low risk patient, according to the calculation that you have just done, you just give a single instillation of gemcitabine or mitomycin. Gemcitabine is what is preferred according to NCCN guidelines. I believe most of us use mitomycin. Intermediate and high risk, you give a BCG induction and maintenance according to the regimen that has been told by the SWOG trial. So what do you do when there is a shortage of BCG? Studies have shown that split dose of BCGs can be given without without a much decrease in efficacy. You can give sequential gemcitabine, epirubicin, docetaxel, valrubicin. There are various regimens for that. Prioritize BCG for high-risk patients. And if you have very high-risk patients, then offer upfront radical cystectomy. So what do you do when MIBC is detected during follow-up? Again, one of the tables I find very difficult to remember, but then, you know, this probably makes it simpler. If you have a BCG unresponsive patient, you offer him, you offer them radical cystectomy, or, you know, you enroll them in clinical trials. If you have a late relapse, that is a TA, T1 non-muscle invasive high-grade recurrence, greater than 6 months, or having carcinoma in situ, you discuss radical cystectomy, or you can reinduce with BCG, or you can even advise bladder preserving strategies. If you have a low risk recurrence, again the same thing, you can reinduce with BCG or offer radical cystectomy. Now, what do you do with variant histologies? We have to remember that 10% of all cases will have some form of variant histology. There are 10 variant histology according to the classification of 2016. So you have a pure squamous cell carcinoma or an adenocarcinoma, you do a radical cystectomy. It is important to differentiate between between adenocarcinoma arising from the urachus and adenocarcinomas arising purely from the bladder. If you have it from the urachus, you do a partial cystectomy. You have a neuroendocrine or a small cell urothelial carcinoma, you give NACT, carboplatin, etoposide, then RC. If you have a micropapillary variant, you do an RC as soon as possible. All the other variants, you know, you need to treat them like any other high-grade urothelial carcinoma. That is preferably NACT followed by RC. So suppose it shows you MIBC. Suppose your biopsy comes out as MIBC. You do a local staging, CT versus MRI. Now there is a lot of talk about VIRAD staging, but here I would like to clarify. See, VIRAD distinguishes between T1 and T2 tumors prior to biopsy. You have already done a biopsy. You have muscle invasive bladder cancer. Why do you need to do a VIRAD staging? You do a proper local staging and you plan the appropriate treatment. So lymph nodal staging, all pelvic lymph nodes greater than 8 mm and abdominal nodes greater than 10 mm should be considered enlarged. For distance staging, CT is advocated. A lot of us do PET. There are no randomized control studies proving that PET is better or CT is better. But this is the only randomized control study in the world, probably, which we have started in our center, where comparison of FDG PET CT with conventional imaging, staging of high-risk renal cancers and transitional cell carcinoma of bladder, very aptly named Copper T trial, where, you know, all patients of MIBC, we do a CT. This is the primary objective. These are the secondary objectives. I don't have a lot of time to read out everything to you, but basically we are comparing as a first line investigation, which is better, as a second line investigation, which is better. And then as a tertiary objective, we are evaluating the prognostic value of FDG PET CT with regards to disease-free status. I have had help in making this protocol from Gopal Sharma, who's not present with us here. Now, health status screening, you know, we talk only about performance status, that ECOG 0, ECOG 1, patient is fit for surgery, but is performance status the only thing? Patients can have cognitive decline, patients can be frail. Frailty is basically the ability of a patient to understand an insult, a physical insult on his body, and to recover from it. So to assess frailty, you have a clinical frailty score, you have a G8 assessment tool. You assess the cognitive status of the patient, and for comorbidities, you use the Charleston's comorbidity index. Now, all patients of MIBC eligible for cisplatin-based therapy, you give NACT. Everybody is, I'm sure, convinced with this. If the patient is not eligible for cisplatin, don't offer NACT. And if the patient, you know, cannot get any of these, you can give a radical cystectomy directly. So you can do a radical cystectomy either by a robotic method. If you do not have a robot, you do it by open method. You have a robot and still want to do open method, do it like I do. And you have, you know, as an adjuvant therapy, you can give for T3, T4 or N1 patients, you can give cisplatin if no NACT has been given. And for those who are not eligible for cisplatin, you can give nivolumab. Now, this is for metastatic transitional cell carcinoma. Most of these, it falls under purview of medical oncologists. So I'll just tell you the part where we select therapy. If the patient is platinum ineligible, that is the performance status is low or GFR is less than 60, then there's no point in giving carboplatin. You can give carboplatin if the GFR is still between 30 to 60. you cannot give cisplatin, but you can give carboplatin, gemcitabine. If the GFR is less than that, then there's no point in giving any platin drugs. You can straight away take this patient on, depending on the PD-L1 status, you can start atezolizumab and pembrolizumab. There are lots of trials, Keynote trial, Javelin trial, which talk about all of these, second line therapies. Now, later line therapies, you detect FGFR mutations pre-treated with platinum. You again have a bunch of drugs which are given. A lot of us do not use it commonly in our clinical practice. Now, I wanted to stress on this slide. You remember when I was talking about the Paris system, I was saying that bladder cancer differentiates by two pathways. The low-grade cancer develops by FGFR3, the high-grade cancers differentiate by a different way. So what the Cancer Genome Atlas, the University of North Carolina, MD Anderson Center have done, that they have done genetic tests by which they have divided bladder cancers into mainly luminal and basal types. And on the basis of this, luminal papillary, luminal infiltrated, luminal, basal squamous, and neuronal. So these are the markers. On the basis of this, they are predicting what will be the treatment for each type of cancer. So this is basically an expression of precision medicine, patient-directed therapy. So this is going to be the future. We are not going to depend on, high-risk fracture, size of the papillary tumor, previous BCG or not. In the future, there will be a time when presence of these markers will tell us whether to give neoadjuvant chemotherapy, whether to do FGFR3, whether to give cisplatin-based chemotherapy, whether to give etoposide cisplatin. So this is a look at the future. We are still to realize it, and to adopt it completely in our clinical practice. Thank you.
Thanks, Rahul, for your wonderful talk. The topic is open for discussion.
Radicals. Sir, there was that paper published in Journal of Urology where they had. Sir, I didn't see it. I may have missed it. I'll go back and I'll check.
Any role of hyperthermic intravesical therapies in this?
Yes, sir. Sir, since I was focusing mainly on guidelines, I did not touch upon those parts.
But I think EAU guidelines have a mention on that.
Sir, so it's meant, so in EAU guidelines, if you see, then there is one white colored table and then there is a blue colored table. The blue color is the one which are the actual guidelines with the strength of recommendations.
I'm actually talking about the clinical practice. So because there is a role in clinical
yes,
practice.
They have mentioned,
especially for the patients.
They have mentioned hyperthermic. Yes, sir.
And for those patients who are not willing for cystectomy,
yes,
even in BCG shortage, BCG naive patients,
yes,
or BCG refractory patients,
definitely, yes,
you
sir,
have that option.
Yes, sir.
You have already mentioned gemcitabine, docetaxel.
Yes,
so this is the other option.
Yes,
I've been
sir.
using that, and 1 year results I have in my patient, they are doing pretty good.
Yes, sir.
I think Puneet's point is well taken. That is the space where there have been a lot of FDA approvals in the last year.
Yes, sir.
And they will also show a lot of changes in the guidelines
Yes,
over
sir.
the next year or so. So I think we'll move on. We have the
Thank you.
kidney section. Thanks, Rahul. And Dr. Srivatsan will be presenting on the changes in the guidelines in kidney cancer.
Right, thank you. I think it's right. So thank you for the opportunity to present it. As I postprandial session, guidelines is the most driest topic to talk on. So let's go on with it. I'm going to restrict myself to both AUA and EAU for lack of time, as well as NCCN is something which we don't follow per se. How do you move this? Sorry. Green button. Right. So this is something which will so fast changing. It's very difficult for us to keep up, especially the medical oncology part of it. I mean, by the time I finish the talk, they would have put up another tweet saying that the first line oncology thing is completely different. So I think we are more into looking into which patient goes into what and more into surgical aspects of it. So I'll try to stick my talk, but most of the changes have occurred in that segment of the population, not in the surgical. Surgery remains almost the same. So Right, so coming on to the AUA is 21/22. Not much changes occurred this year, but then I'll get on to the 21/22 guidelines which they had released. So these are the various guidelines changes that has occurred. Again, I'm going to stick only to the changes that has occurred from yesteryears to today. Right, so there is an updated risk-based surveillance protocol which has been introduced, expanded indications for genetic counseling, issue of adjuvant therapy post-nephrectomy. That's a very important portion which we are all confused. MRI with contrast to be used even in CKD patients. Just remember, because we used to restrict ourselves with the GADO use in creatinine more than 2. So this, they have strongly mentioned that you can use it. Indications for RMB biopsy, emphasizing on a utility-based approach, and the issue of deciding between radical and partial is now more clearly stated, and the indication and rationale of active surveillance is also precisely put in, which is very important because there was a lot of confusion in the follow-up protocols as well. In MRI, as I mentioned earlier, the risk of nephrogenic fibrosis with second generation GADO is extremely low. So please use gadolinium based MRI if you can't use a CT contrast in CKD patients. So this is one change which is very different from the yesteryear's guidelines. The rest of the all, metastatic evaluation and everything is the same as before. Only thing, CKD stage based on degree of proteinuria and GFR has to be done before you decide on the treatment protocol. Coming to the renal mass biopsy, again, there is a slight change in the terminology or the wording of the guidelines. If you see, the language has been changed to an emphasis on a utility-based approach. In any patient, if you feel it will help you decide on the future treatment, please do a biopsy. There is no indication, there is no restriction. I know the exam-based question is that you will do a biopsy if there is any lymphoma, metastasis, inflammatory or infectious. But they say, if you feel that it will help you in deciding the future treatment, please go for a biopsy. It has no whatsoever implications on the future, change in the quality of life or anything like that. So biopsy is actually not required for young, healthy patients who are unwilling to accept the uncertainty associated with it. Older, frail patients who will be anyways managed conservatively, independent of the biopsy, again, you can avoid it as well. Always a multiple core CT-guided biopsy over an FNA. Now, counseling the patient, again, the urologist has to be the center point of counseling, including an MDT with radiation and medical oncologist as well. Counseling should be twofold, one towards the disease as well as to the genetic part of it. Again, all the aspects, including CKD and the need for future dialysis, what kind of a modality treatment post surgery or without surgery, all has to be put forth to the patient in perspective. Again, coming to the genetic counseling, very clear guideline has been placed. All patients who has presented to you less than 46 years of age, those especially with multifocal and bilateral renal masses, or whenever there is a personal or a family history suggesting of a neoplastic syndrome, if there is a second or first degree relative with a history of renal malignancy or a known genetic diagnosis which is related to our conditions, the pathology of the patient demonstrates histological findings suggestive of a syndrome. This has been expanded because we feel that 4 to 6% of all cases of RCC are now thought to be familiar. Now, this partial nephrectomy and nephron sparing, this is almost the same. We have to prioritize saving, nephron saving approaches in any kind of patient, especially in patients with an anatomical or functionally single kidney, bilateral tumors, familial RCCs, pre-existing CKD or proteinuria if you find it prior to the surgery. In spite of all this, young multifocal masses, comorbidities that are likely to affect the renal function, you have to consider NSS. The principles of NSS will remain the same. Decrease the warm ischemia, negative surgical margins. The extent is to be decided by the surgeon intraoperatively. Enucleation is the treatment of choice in patients with familial RCC or multifocal, or where you need to save as much as nephron as possible. Coming on to the active surveillance, and this is again a very important topic, they have given the size criteria which was not there till date. The size of less than 2 centimeters or those that are complex but predominantly cystic, you can offer AS as a first solution to them. And this identification is only in this 2021/22 guidelines, not before. And when should you do a repeat cross-section? You have to do it at 3 or 6 months, and then you decide the future follow-up depending upon the growth rate. If you have a substantial interval growth in this CT, then you will have to hasten up your follow-up protocol or switch them over to a definitive management as well. These are all the various factors. This is all textbook, this thing. I'm not going to go into that, okay? Right. So this is the protocol follow-up which was given by the AUA. You divided them into 4 categories: low risk, intermediate risk, high risk, and very high risk. This is according to the stage as well as the grade of the tumor. If final microscopic margins are positive, you have to upgrade them. Most of them says you upgrade them to the high risk category and put them on a very strict surveillance protocol. But basically you at least upgrade them to the next stage, so that you can put them in a better surveillance protocol as well. This is the various protocol. This has again been staggered. If you see the low risk and all, it's just at 12 months, whereas higher risk comes at 3rd monthly interval as well. The various tests done are history, physical examination, labs, abdominal and chest imaging as well. So coming on to the EAU guidelines, which is the most common guidelines that we follow. Coming on to the chromophobe RCC, they have found that there is a very good, recurrence-free survival rate at 94.3 and 89.2. Recurrence does occur very often, 5.7% and 76.5% with distant metastasis. So though it is rare, it is still could be over a long follow-up. So, but still you should understand the prognosis is not unlike sarcomatoid or anything good. Again, coming to the metastasis, I'm just going through a few lines of this thing before going on to the recommendation. The brain metastasis again should be, it's not too bad. You have to treat it. Anybody over the more than 2 extracranial, including lung metastasis, you have to give a radiotherapy, and the overall survival is not too bad, about 10.3 months. So coming to the actual recommendation per se, again, coming on to the genetic counseling, this is ditto the same as was given by the AUA recommendation. Anybody over the age of 40, less than 46 years. So for the postgraduate, the age criteria is 46 years, and obviously bilateral family history and so forth. Always a genetic counselor should be involved. Again, the same thing. The one thing which was very unique was that the lack of a syndromic manifestation does not exclude a genetic contribution to the cancer development. So please don't only look for VHL and tuberous sclerosis and all those things. Anybody without it also need to be very, very careful with the history and all those things, and involve a genetic counselor as well. Laparoscopic versus robotic approach. Now, this controversy will never come down. They did find that, especially in hilar tumors, there is a slight decrease in the warm ischemia time and comparable positive surgical margin, but there is actually no difference much between the laparoscopic and the robotic method as well. Coming to transperitoneal and retroperitoneal, again, when you match it, there is no difference between postoperative complication, PSMs, early and late EGFR level. However, intraoperative and surgical complication was slightly higher and operative times lower in transperitoneal, which was slightly surprising to me as well. Coming to preoperative embolization, they have given a very good response to reduce blood loss. So they do recommend a preoperative, even in partial nephrectomy, according to the guidelines as well. So coming to the summary of the evidence, the most important thing that I want you to this thing is this radical nephrectomy for a positive surgical margin after a partial nephrectomy will result in over-treatment in many cases. Please keep it in mind. Don't rush to take out the kidney which you have found to have a positive surgical margin. Rest are all almost the same. Coming to the other recommendation, do not perform minimally invasive radical nephrectomy in patients who are feasible for partial. If you have no experience with laparoscopy or robotic, do an open partial nephrectomy. Do not perform minimally invasive if you feel that you will compromise oncological, functional, and perioperative. And this is not given by Indian guidelines, this is by European guidelines as well. Intensify follow-up in patients with a positive surgical margin, especially in an upstaged PT3A patient. So you have to put them in the highest risk protocol follow-up, which is every 3 months. Right. So coming to the active surveillance, I think the one thing I wanted to point out in this was that the clear cell RCC grew faster than anything else. So if you see 0.25 and 0.02 centimeter per year on an average, you have to keep it in note that they found out that 6 patients developed metastasis and all of them belong to the clear cell RCC. Finally, whatever transformations, sarcomatoid, and whatever we talk about, clear cell is still common and is still the most aggressive of all the RCC, and that's very important for us to understand. Now, coming to a very controversial topic, in fact, is adjuvant immunotherapy or adjuvant therapy after you've done the surgery. Now, we still don't have any much clarity as to whether it's required or not. However, there is some data and there is a guideline offered, though the strength is quite weak. offer adjuvant pembrolizumab in patients with clear cell RCC with curative intents if you find that there is a risk of recurrence as it was defined in the trial. So if you have a patient who is high risk and there is a very high chance of recurrence or micrometastasis, adjuvant pembrolizumab is very, very important. And this is based on all this trial, especially the Keynote 561, this thing. So what is that primary metastatic disease? What is the current guideline? So I'm not going to go into each and every this thing because that's going to run into pages and pages of it. So I'm just going to directly go to what is the recommendation. The first recommendation that they have given is offer immune checkpoint combination therapy for advanced clear cell RCC with sarcomatoid feature. And the second, this thing, again, I'm going to skip all this for the lack of time, is directly go to this one table, which will tell you what is to that is you should know as a urologist. So if you have an IMDC favorable risk, the first standard of care should be nivolumab and cabozantinib, and the second should be a pembrolizumab and axitinib in the order of preference and the order of tolerability and so forth. And the third would be a pembro with a levonatinib. If it is an intermediate or poor risk, then the first should again be the same, nivolumab with cabozantinib, and the rest follows it according to the tolerability and the affordability of the patient. And this is the only side that you need to know. All the recommendation and all these things quite confusing, and at the end it keeps changing every 3 months. So this is the last recommendation by EUA that we should follow in order for exam or any other purposes as well. Right. So in sarcomatoid feature, slightly different. So you have the immunotherapy is still superior. So you please offer checkpoint immunotherapy for these patients with sarcomatoid features as well. When it comes to non-clear cell, again, sunitinib is good, but still other inhibitors are not that effective. So you should offer sunitinib the first line of therapy. This is the final recommendation for non-clear cell. Cabozantinib improves over sunitinib. So this now will become the non-clear cell criteria for the recommendation for the first line management as well. Coming to the renal medullary cancer, this was included in the EA recently. So I'll just skip that as well, nothing major. The one thing I wanted to end this with is the new drug which has come in VHL, belzutifan, which is written in the EAU guidelines. And this has been approved by the FDA for the treatment of clear cell as well as the VHL syndromes as well. So with that, I end my talk. Thank you.
Thanks, Srivasan, for your wonderful talk. A quick question to the expert, sir. After the renal mass biopsy, did you feel any changes while operating, especially for a partial nephrectomy?
No.
I think with the CT guided biopsies that we do, probably I don't even wait for 2 or 4 weeks like prostate. I just go in and take it once the biopsy is ready.
Right.
Great talk, Srivasan. Just one for my curiosity. Why did they reach that 46 years? Any particular?
And
No idea, sir. Especially 46 is so high poppy. I'm like, why 40?
And it's only on the basis of age that you will refer this patient for this thing. It does not require to have any family history, no multifocal.
Anybody less than 46 with no other history
other
should be
history,
referred
yes,
for
sir.
genetic counseling. And anybody over that age group with all the risk factors should be sent for it. Yeah, please, sorry.
Yeah.
I'm not sure whether that's a metastasis or another lesion of its own, but I think he would definitely benefit. I mean, I would more rely on another new tumor coming on the other side. So I think he will require being a bilateral renal masses. I'm talking about Bosniak 2B to 3. No size criteria for that. 2B to 3.
Okay, thank you.
Thank you. Okay.
We'll
Thank you,
move
guys.
on.
So now we are moving on to the upper tract TCC. We all know that relatively are dreadful magnets when compared to urology perspective, but least concentrated generally. So I think in this meeting we have focused on mainly on the upper tract TCC on some focus topics. So first I invite Dr. Kinju Adhikari to speak on bladder cuff excision, how important is in treatment of upper tract TCC.
Which one is the arrow? Good afternoon. In the outset, I'd like to thank USI and youth for giving this platform. I'll be speaking on bladder cuff excision under the domain of upper tract urothelial carcinoma. We know that upper tract carcinoma is a relatively uncommon disease, and this gives a picture of overall how the outcome in terms of survival it has been over 3 to 4 decades. The survival has not significantly changed. So this gives us a perspective on, this is not just we are dealing with upper tract, but also the recurrences in the lower tract. So are all urothelial carcinomas the same? Moreover, yes, and also no. There are some innate differences in terms of anatomic as well as embryological as well as molecular differences. The rate of recurrence in the radical nephrourectomy after the surgery in the bladder is almost up to 47%. And the concurrent bladder cancer is generally about 17%. Thus, the role of intravesical chemotherapy as well as single intravesical installation that we always talk about. So why does this occur? There are various theories. Among them, the most accepted one is the clonal theory and the field change theory. The only difference between these two is that in the clonal one, there is one cell that gets transformed and then gets seized down to the lower tract. In the field change theory, there are multiple cells that gets transformed, and there might be multifocal diseases that might or might not be related to each other. The others are longer exposure time to carcinogen in the bladder and a greater number of urothelial cells in the bladder. This forms the basis of why we need to do a bladder surveillance even after radical nephrourectomy or even after sparing the nephrons. Who are the patients who are more likely to reoccur? This is the meta-analysis that has been published, which says that the factors such as invasive disease, high-grade diseases, multifocality, tumor diameter, all these smoking, all these are the factors we play into the role in increasing the risk, as well as this also plays a factor where we can counsel the patient that you are in the high risk of developing a bladder recurrence. Where does it recur? Mostly it recurs in the ipsilateral ureteric orifice, also at the previous site of nephrourectomy, also and in the wounded bladder epithelium. This gives us a basis where we need to and why we need to excise the bladder cuff. This is the sheer data amongst thousands of patients that has been given, and we can clearly see that the cancer-specific mortality rate is high in where nephrourectomy with cuff cystectomy has not been done. The other part is wherever the ureteral stump is remaining or wherever we have left the ureteric stump, the recurrence here is as high as 75%. The same thing is here. If there is recurrence in the bladder, the death is as high as 3-folds. It's 22% versus 57% in terms of 5 years survival. This forms the overall basis of why we need to excise the bladder cuff. Going on towards the technique of excising bladder cuff, I will not be dealing about the radical nephrourectomy and the lymph node dissections, but overall the oncological principle that we tend to follow is that we don't go into the upper tract, and the tumor seedling is to be avoided. In terms of ureter, it's always prudent for the surgeon to ligate the ureter just to prevent the seedling towards the lower urinary tract. In terms of bladder cuff excision, the en bloc is always the rule, and entire distal ureter, including the intramural portion, as well as the ureteric orifice and cuff of a bladder has to be removed. Various techniques has been defined. Amongst those techniques are extravesical technique, intravesical technique, open, robotic, laparoscopic. So all these are based upon mainly the surgeon's preference and also the comfort level. Extravesical technique I'll be explaining in the video later on. There is a combination of extravesical as well as intravesical technique where we give an anterior cystostomy incision and then see the ureteric orifice and remove everything under vision. This is the transvesical ligation, mainly use the robotic laparoscopic port, and we use an endoloop to form a closed loop system just to prevent the ureter urine seedling and overall preventing the bladder recurrence. It forms the closed systems here. Plug technique is not really common. It's not is largely abandoned also because of the potentiality of leaving the ureter incompletely resected as well as seeding extravesically. Similarly, stripping technique, it is also contraindicated in presence of distal as well as in the ureteral tumor. Is largely not done. There is a inherent risk of exposing ureteral mucosa to the bladder epithelium. Again, hence the increased risk of recurrence there. Stapling method, the concern about this method is that we might leave a positive margin of the ureter there. Also, its advantage would be, it might be slightly easier and faster to do it, but generally not advisable for a patient who have a distal ureteric tumor. This is overall the comparison of all whatever I have said before, except for the ureteral stripping as well as the pluck method. None of this technique is inferior to the bladder cuff excision. So how we do it? Generally, we start off with cystoscopy. We have been shifting from open to lab to robotic. Most of our volume is robotic nowadays. This is the port position as well as the position of the patient. This is the port configuration for SI robot. The only difference with the standard radical nephrectomy here is the distal most or third arm port is placed a little bit distally and medially. Apart from that, everything else is similar. This is the configuration for XI robot. It's pretty much same. It's in the straight line. This is the video of robotic radical nephroureterectomy. This is using XI robot. So the difference between the XI and XI here is that in SI, it's relatively difficult to do multi-quadrant surgeries. Yet I'll not be focusing more on the radical nephroureterectomy part. I'll be just going on towards dealing with the distal portion as well as the bladder cuff portion only. So the standard excision of the vessels and starting off with the nephrectomy part here. Regarding lymph node dissection, it is not a rule that you'll have to do lymph node dissection right now only. You can do it later on as well as it depends upon your comfort and whatever you practice in your center. We have removed here the hilar lymph node right now. So the main aspect here in nephroureterectomy is that the ligation of the distal ureter. It is of greater importance just to prevent the bladder recurrence later on, because once we go and fiddle the tumor in the upper tract, there is a chance that the tumor might seed into the lower tract and there might be the chances of recurrence later on. So this is just about completing the nephrectomy part as per se. In the SI robot, we generally tend to redock the system, and XI it's not really required, and port hopping is also generally easier. Here we are just following the course of the ureter distally towards the bladder. The aim is to reach towards the bladder and ureteral junction. The idea here is to preserve at least a little bit of tissue surrounding the ureter so that we don't go ahead and fiddle the ureter as well as the upper tract too much. Any small vessels or artery that come into the way, either we cut it or we clip it. There is no absolute need of controlling the lateral pedicles in robotics, especially it's easier to go towards the uretrovesical junction and it's not really needed. However, we tend to slightly medially mobilize the bladder in terms of the accessibility. Accessibility to the surgeon, later on to the suture, as well as the visibility would be better. Also to the assistant for assisting and this visibility overall. So here we are just going distally towards the uretrovesical junction. The main aspect is to remove the intramural portion of the ureter as well as to remove under which and everything the ureteric orifice as well as the cuff of it. Here we are doing the same. We are just going towards the bladder. Once we see the bladder mucosa, it is prudent for us to see the contralateral aspect of the contralateral ureteric orifice also. Injuring the contralateral orifice while doing the bladder cuff excision has happened, especially in open cases. So that we should be careful. Here we have already opened the bladder. We are seeing the bladder mucosa. The only thing we'll see next is that we remove overall the intramural portion of the ureter. We are seeing the contralateral ureteric orifice and excise adequate amount of bladder cuff. one trick that has helped me especially is that before excising over all the ureter right now only, we tend to take a stay suture initially. This helps mostly in the open surgery rather than robotic. However, we tend to, if we miss it, the ureteral mucosa goes retracts backwards. Also, the bladder wall retracts backwards. So this might cause some compromise in the watertight anastomosis in the bladder. We have used a 3-0 V-lock suture here. The catheter we place for around 10 to 12 days. This is a comparison between laparoscopic versus open nephroureterectomy. Overall, there is no difference in terms of cancer-specific survival and open and overall survival in 2 to 5 years. This is again a comparison of robotic versus lab versus open, and there's again no significant difference in overall survival and cancer-specific survival, but there is one advantage that has been seen here is that the likelihood of lymphadenectomy in robotic is higher. As we can see here, it's 33% versus 17% in robotic as compared to laparoscopy. So finally, bladder cuff excision has shown superior oncological outcome in radical nephroureterectomy. Different techniques has been described and they are almost similar, having similar outcomes. Plug technique and stripping technique are not advised. Robotic platforms, even the laparoscopic platform, all the minimally invasive platforms have their inherent advantage of being minimally invasive, and robotic has shown a better yield in lymph nodes after radical nephroureterectomy. Thank you.
We'll take questions now.
So it depends, sir. If the tumor is locally advanced, as you are saying, if that is what I understand, if it is a locally advanced distal tumor going protruding into the bladder through the ureteric orifice, or even outside, if it is a T3 kind of a tumor, we generally don't go with minimally invasive. Here, the outcome, oncological outcome is more important rather than going through even robotic or laparoscopic. Although having said that, there are techniques that we can do endoscopically also under vision in terms of removing whole of the ureteric orifice as well as the intramural portion also, and then going ahead and doing the surgery. But we would most likely not do minimally invasive here. Generally, the infundibulopelvic ligament and the vessels would come there. If it is there and if it is causing obstruction, we tend to excise it and then we go ahead and go do the regular bladder cuff cystectomy. Yeah. Yes. So number one thing, as I already said, is that from upper tract, if we are dealing with, we clip the ureter initially only just below the primary disease. So second thing is that to avoid the spillage that you are asking, there will always be a catheter that would be draining the urine. So as long as we are doing it in a controlled manner, there should not be any spillage. Even if there is a spillage, the literature says that the peritoneal metastasis, even if it occurs, it's 1 to 2%. Yes, so, we generally take the stay sutures initially. So as when we are excising the ureter, before excising completely the ureter and the bladder cuff itself.
Answer your question, she showed in the video a stitch help. So instead of taking a one stay stitch, you should take two opposite stay stitches. So
that will be most helpful in open situations. Whenever we are operating in the deep pelvis, we are with the bladder mucosa and the wall tends to retract.
Even in robot. Yeah, so opposite you have to take. Even in robotic, when you're doing with a single docking, it helps a lot because patient is in lateral position. So stage is there. And second thing to prevent seeding was if it's a renal pelvic tumor or before doing a bladder cuff, always clip the ureter, mid ureter. And if it is a lower ureter, then you should actually clamp if possible or not. One more point I want to add is whether you do bladder cuff endoscopically is now obsolete. We don't core in the bladder, or transvesically or extravesically. So transvesical or extravesical does not have any difference in intravesical recurrences or recurrence-free survival or overall or cancer-specific survival. But endoscopic, if you are doing, it is seen that the rate of intravesical recurrences are higher as compared to transvesical. So endoscopically, you should not do. Whether you do extravesical or transvesical, that does not make a difference.
I just back the history just back it immediately. Don't let this thing because proximal
Yeah.
Okay. Can you move to the next speaker? I request Srikant Atluri to take on this segmental uretrectomy.
Thank you so much, USI and youth, for giving me this opportunity. So today I'm going to talk upon segmental uretrectomy, how and why I do it for TCC. Which one is this one? Yeah. So before we answer the questions of why and how, we answer when we do the distal uretrectomy or segmental uretrectomy. So if you see the NCCN guidelines, so it typically divides it into upper, mid, and distal ureter. So it recommends segmental uretrectomy in mid ureter, especially when the tumor is of low grade. So it can be offered in place of endoscopic resection or an FROU, where we excise the tumor bearing tissue and then anastomose the rest of the ureter. While in distal part, whether the tumor is high grade or low grade, still it recommends to do a distal uretrectomy. And especially when the tumor is high grade, we have to do a regional lymphadenectomy along with a bladder cuff as stated in the previous talk. While European Association divides upper uretary tract tumors into high risk and low risk. So low risk tumors are unifocal tumors, less than 2 centimeters in size, low grade tumors, and no negative high grade cytology, non-invasive on the scans, while rest all are put into the high risk feature, high risk upper tract tumors. So typically for the ureter, it divides it into the management in mid and proximal part and distal part. So if you see here, the European recommends segmental uretrectomy for low risk disease in mid and proximal part, especially it is the mid ureteric part. But if you see here, it recommends in case it is not amenable to endoscopic treatment. While for distal ureter, it recommends distal uretrectomy for low risk as well as high risk, especially with lymph node dissections and neoadjuvant chemo if it is a higher. So these are the situations where we do segmental uretrectomy, and the advantages are it is less morbid, and the main aim is to preserve the nephrons. So coming to the indications, as we have seen the tumor related indications, especially in the distal ureter, we do a distal uretrectomy with a bladder cuff, with lymph nodes, and with or without giving him a neoadjuvant chemo. While in mid ureter, it is mainly recommended for low grade disease when it is not amenable for endoscopic management. And for bilateral disease, especially when we have to look in for the nephron sparing, then also it is indicated. While the patient related factors are solitary kidney, where we have to preserve the kidney function, or already the patient is having some CKD component. And sometimes you may have to give them a post-operative platinum-based chemotherapy in such patients. So there we have to look for these kidney preserving surgeries. So the concept of uretrectomy or kidney preservation started as a conservative or a palliative treatment approach in late 1980s, where the urologists or surgeons used to do this when the patients are not fit for the radical surgery, and those are with a lot of comorbidities and frail patients. But gradually, as science and technology both advanced, they, from the palliative intent, they shifted it to the curative intent. This is a systematic review by the EAU panel, which was published in 2016. So we know that these tumors are have a very low incidence. So as we can see, they have only 22 non-randomized comparative retrospective studies published, which were included in this criteria. And they compared segmental uretrectomy with radical nephrouretrectomy, as well as URS and PCN percutaneous treatments with radical nephrouretrectomy. So what they found was that there is no significant difference between both the groups in terms of 3, 5-year and last follow-up cancer-specific survivals. But we need to take this data with a pinch of salt, because as it is a data which is poorly reported because of the retrospective non-randomized comparative nature. And there was obviously a selection bias in these studies, because the more favorable, like low risk groups, were taken into the uretrectomy or kidney preserving groups, while the higher risk groups were given into the nephrouretrectomy patients. So coming to the segmental uretrectomy, these are the surgeries which we can perform. So distal uretrectomy with ureteric reimplantation with or without Swas hitch or a Bovary flap, and segmental uretrectomy with ureterostomy or other transpositions like transureterostomy or ileal ureter or renal uretero. This can be done both open or minimal invasive, laparoscopic or robotic. So we all know the advantage of minimal invasive surgery. We can do laparoscopic, robotic, depending upon the comfort of the surgeon. Patient position, if it is open, we do it in supine, while for robotics or laparoscopy, it is lithotomy with Trendelenburg. Incision is Gibson incision for open, while ports are standard port position for the robotic or laparoscopic prostatectomy. So when we do the distal uretrectomy, as you know that we mobilize the ureter and we take a bladder cuff and all, the most important aspect is how to get a good positive outcomes with a good negative proximal margins. So we can see the tumor which is present, which is seen as a bulge on the ureter, or you can document the tumor with the intraoperative ultrasound and see the proximal extent, or you can use ICG, which where the tumor bearing area will not glow while the normal ureter will glow, or you can use intraoperative ureteroscopy like in the picture here in the second one. So the ureteroscopy can be used just before we cut the ureter, where we can see the glow there, and then we can cut it here. Or you can use after you cut it, where we do use a flexible ureteroscopy and we put it into the proximal ureter, and then we send the frozen sections and make sure that the margins are the negative. So coming to ureteric reimplantation, refluxing versus non-refluxing, as such in adults, it has been shown that there is not much difference, but non-refluxing anastomosis, usually it is done with the extravesical approach, and the advantages are that it is quicker to do, and the rates of strictures are low, and we get an extra length of ureter which may be used in for a refluxing anastomosis reimplantation, because we do tunnel the ureter where we may have loss of ureter there. So again, depending upon the loss of length of ureter, if it is 4 to 5 centimeter, we can directly reimplant it. If it is more than 5 up to 8, then we may need to do a Swas hitch. And for more than 8 centimeter defect, we have to do a Bovary flap. So we do typically with this reimplant over a ureteral stent. We keep a good wide bore Foley catheter and a drain. Drain is usually removed in 2 to 3 days when the output is low. Foley catheter is typically kept for 7 to 10 days, and stent is removed in 6 weeks. And as a lymphadenectomy, it is recommended in high-grade disease. So segmental uretrectomy, similarly, if it is a loss of a ureter of around 2 to 4 centimeter, we can primarily anastomose by mobilizing the both proximal and distal ends of the ureters. But if there is a more loss of length, then we have to do these all transposition like transureterostomy or replacements. But usually these surgeries are very rare. So very low number of cases, very highly selected patients will be offered these kind of surgeries. Coming to complications, the early complications is urine leak, so tension-free anastomosis and watertight anastomosis with good vascularity is the key. Patient may get UTI, and in the delayed, there may be a stricture formation, there may be a recurrence. Then we may have to deal the recurrence depending upon how the recurrence is and where the recurrence is. Follow-up, typically when we do a segmental uretrectomy, we have to have a close follow-up. So we do a cystoscopy and cytology every 3 months for first year. Then for next two years, it is 6 monthly, and then every yearly. And then we also do a cross-sectional imaging in every 3 to 12 months in first 5 years. So this is the video of
were used.
distal uretrectomy.
We start
So
the
this,
surgery
this
by
was a
mobilizing the
female
sigmoid
presented with
colon and its
72,
mesentery.
She was a 72-year-old female with a lower abdominal pain, and on imaging was found to
The
have
ureter is then
mass
identified after
in the
mobilizing the
distal
colon.
ureter.
It is seen
So
just above the
first we
level
start
of
with
common
identifying
iliac
the
where it
ureter.
crosses over.
Gradually we start to
Ureter
mobilize
can be
it,
identified by watching
and,
for its peristalsis.
we try to take
Once
as much as
identified,
tissue,
it is dissected
periureter
and
tissue for
slinged.
having a good margin. Then we sling the ureter so that we have a traction, and then we were able to mobilize the rest of the ureter.
Here, we see that the
Then we use
ureteral
this
mass is
ICG,
not
which is
seen
a
as it is intraluminal.
given intravenously, and then
We
as you
inject
see, the normal
ICG
ureter will be looking
intraluminally
green.
and watch it under the firefly
You
mode.
can also see here the
Well, we can see
water
that under
stent
the
also looking
firefly
as a
mode,
green.
the ICG lights
But the
up.
tumor
The normal
bearing
ureter
area will
that
not
does not
glow.
do
So this is the
it loses
proximal
signal.
area where it is not glowing, where the tumor is. So that is how we identify with the help of the ICG. So this is the
We
normal
can see
ureter there.
here that the normal ureter is very brightly
So
lit under
now
the
we know that
firefly
here the
mode.
tumor is there. Now we will be starting to mobilize the ureter more proximally, so to get a good adequate length.
The next step
And
is to
similarly,
identify
then we
the
go
proximal
distally
extent
and
of
do
the
a
mass.
bladder cuff excision as shown in the previous talk,
Firefly
because
is a
it definitely
software which
reduces the
uses
risk of
near
recurrences. So
as there
bladder
was
cuff is
suspicion of
done in a
malignancy.
typical
We dissected
fashion.
the lower end of the
So
ureter till the
discussed
bladder
earlier.
and excised a part of the bladder cuff.
We do take a stage
And the
suture,
stage suture
as we
was taken.
discussed, because we don't want the mucosa to invaginate. We have a good watertight closure. So this is the proximal ureter.
Here
which
we
is
can
again
beautifully
glowing,
see the
distal ureter
delineation
glowing,
between the
and
healthy
tumor
and the
is there.
diseased
This is how we
ureter under the
identify
firefly mode.
the proximal part and the proximal margin. This is one of the way. And then we try to cut the ureter there, and before that we sling it and tie it.
Proximal uretral end is then
And
looped
then once we
and
cut
tied
it, we
with a
also send
suture
it for
and
a
then
frozen
clipped.
section to look for any
Double
margin
securing
status.
the segment of the ureter helps in preventing tumoral spillage at the time of retrieval. The clip is then also confirmed under the firefly to check for its location.
So once we loop it, so we tighten it so that there is no spillage.
Confirming the
And
clip
then we
under
cut it.
firefly
So we
helps
can
us
see
to
here that
ascertain
the
that there is
normal
no
ureter is
accidental
glowing there.
clipping of the
So
mass tissue.
we are pretty much sure that this will be most likely a normal one. And then
The same
keep
thing
the
is
distal
done
end also
distally.
to prevent spillage.
The distal ureter is then cut and a small
And take a
portion of the
bladder
bladder cuff is also excised.
And
The
then
normal
we bag
uretral
the
orifice
specimen as
is then
rightly
sutured
pointed out
closed
to
with weave of
prevent any
tubes and
additional
pumps.
spillage and close the bladder cuff. And then this is the proximal part which is being cut now.
The entire segment of the ureter was then sent for an
After this, we
intra-frozen section.
typically re-implant it
The
depending
frozen
upon
section
the
did not
defect there.
reveal any
So this
malignancy,
patient has
and
quite
hence
a big
uretral
defect, so we had to do a
reconstruction was
Bovary
decided
flap.
to be done by a
So
Bovary
you
flap.
see the ureter is not coming
For
down
a
very
tension-free
easily beyond the
anastomosis, the
iliacs.
proximal
We
ureter was
immobilize the
dissected
bladder
and
here,
the bladder freed from its
and then
attachment
we
and
mark the Bovary
mobilized.
flap.
Length of the Bovary is judged by comparing it with the length of the robotic
Bovary flap is
instrument.
typically a triangular board-based flap. With a good vascularity, we maintain it.
All principles of
And
adequate
then it is
tension-free
anastomosis to the
anastomosis were
ureter over
followed,
the stent.
namely preservation of the blood supply, a tension-free anastomosis, removal of the unhealthy ureter, and adequate mobilization of the bladder and ureter.
So stents can be inserted from below or from the assistant port, whichever the surgeon is comfortable with.
The Boari flap was then tubularized over a 8 by 26 DJ stent and sutured
That's how we
with
complete the
Vicryl 30 in a
anastomosis.
continuous
Thank you.
manner.
So I think we'll take the questions at the end for all these topics. Can I invite the next speaker, Dr. Siddhalinga Swami, to speak on the endourological management of upper tract TCC.
Respected chairpersons and respected seniors and the youth section of USI, welcome you all to Hyderabad. So today I'll be talking on the endoscopic management of upper tract TCC. So why and how it can be done. So as you all know, has been discussed many times, TCC accounts for 10% of the tumors, 2 to 5% are seen in the upper tracts. The mean age of presentation is 65 years. The staging and grading of these tumors are same as the bladder. The traditional treatment has been nephrouretectomy, radical. But because of the high success, high rates of recurrence and disease progression with the less extirpative surgeries, radical nephrouretectomy is the gold standard still going on. So minimal invasive treatment was opted for only patients who the surgery is deemed to be difficult, like open or lap or robotic, if they are not fit, or if there is a bilateral disease or underlying comorbidities. So I have to say that 1985 is the year when this first endoscopic resection of a tumor was done. So since then, we have two options of resecting an endoscopic tumor by either ureteroscope or a percutaneous approach. So overall, so this has been discussed already. So just want to highlight in all the low risk, whether it is mid, upper, or in the kidney, in the calyx, anywhere, the first choice is ureteroscopy. So what do you mean by the low risk is defined there? That is unifocal disease, tumor less than 2 centimeter, a low grade cytology, low grade on ureteroscopic biopsy, and also a non-invasive aspect on a cross-sectional image. So we have two approaches, that is ureteroscopic and percutaneous approach. So ureteroscopic approach is the least invasive method, best treatment initial. We have to do the ureteroscopic biopsy before planning for any other procedures to confirm the grade of the tumor. So initial cystoscopy and initial ureteroscopy is the mandatory thing. Serving the whole calyceal system as the advantage and the best modality to approach the ureter renal pelvis, which is less than 1.5 centimeters. So main advantage is the limited morbidity, outpatient clinic, you can do it. Potential oncological benefit is the closed system. Appropriate patients are solitary kidney with compromised contralateral kidney, size less than 1.5 centimeter, sessile tumor, tumors of grade 1 or 2 disease. Disadvantage, the bulk, mainly the potential staging errors, because whatever the biopsy, what you take are very small, minute bits, you may miss the diagnosis there. Inability to treat a large lesion, a sessile lesion, and difficult to assess the lower pole lesions in the pelvis. Percutaneous approach has this advantage of treating it, a large burden can be treated up to grade 1 and 2, limited to the renal pelvis, calyces, or even the proximal ureter. It's crucial that a grade 3 disease has been ruled out before planning for the percutaneous approach. Best choice for lower calyceal, urinary diversion, and a continent diversion definitely requires PCL. So advantage, large endoscope, large room, you can do the procedure better irrigation. Both rigid and flexible endoscope can be used through the percutaneous access so that all the calyces are meticulously covered. And a second look nephroscopy and biopsy can be done. Installation of adjuvant therapy is easier when we do a percutaneous approach. Disadvantage, increased risk of breach in the continuity of the urothelium and greater morbidity, bleeding, and the surrounding organ injuries as commonly seen. So instead of identifying which procedure is better, both of them have to be taken as a complementary procedure, not the competitor, so that when you take a case for endoscopic management, get the consent for both of them in a single anesthesia, you'll be able to give the better for the patient oncologically. So first and foremost, before starting, always have a biopsy. So this is mandatory to rule out the grade 3 disease. So different tumor types requires different types of biopsy material. Like if there is a sessile or a CIS, brush is enough, you'll get the tumor cells there. If there is a papillary tumor, then this kind of flat wired basket, it cuts the tumor like a knife and you'll get a good chunk of the material for the biopsy in one go. And it can also be used to treat very small low-grade tumors, which we can just pluck it out. Cup forceps has been standardly used, and the problem is the biopsy material is very, very less there. And the fluid which we get can be sent for the cytology. Narrowband imaging, yes, helpful whenever there is a recurrence or when you're doing an surveillance. If there is a suspicious lesion, you can use this definitely for all the tumors inside the kidney there. So lasers have been the main way to go about these endoscopic resections. Laser, efficient technique, beam coagulates the tumor and also able to remove the tissues and treat them effectively. The development of smallest fiber, now we have 150 micron laser fiber with the thulium fiber, which gives a good accessibility, good vision, because of irrigation flow will be better. Semi-rigid and flexible has been enabled and include the most of the lower pole tumors are also been able to manage with this. So standard Nd:YAG laser has been in the market and still it is the better modality for upper tract tumors because of coagulation effect. It burns the tissue and the depth of penetration is 4 to 6 mm, which is required in a tumor to control the bleeding and also to reduce the size of the mass. Holme-MAG laser, the depth is less than 0.5 mm, which you can use it to coagulate a point-based disease, or you can remove that scar which has been done after the Nd:YAG laser has done. So thulium MAG and depth reduces the bleeding and mucosal perforations and improved ablation even if the tumor size is less than 1.5 centimeter. The latest one is the thulium fiber laser. Promising tool because of better energy absorption, limited penetration, limited carbonization produced by the ablation zone. And a recent study in 2018, they have seen in 11 patients over 6 months, there has been no recurrence there. So coming to the technique of an endoscopic management here. So this is a small case which was done, very small tumor. Easily we were able to coagulate and excise that scar completely. So small diameter grasper or electrode or a laser fiber that pass through the working channel has to be used. And the order of mechanically remove large volume of papillary neoplasm, the grasper has to be passed multiple times, which helps in clearing them. And the base of the tumor is then fulgurated, likely eradicating the base while maintaining the integrity of the ureter and minimizing the risk of the ureteral wall. So electroresection, this can also be done with a 12 French, 13 French ureteroscopic resectoscopy, and be used effectively in resecting the TCC of the distal ureter. Alternately, an electrode probe which can be used for coagulation or high vaporization or cutting mode. Cutting approach, risk of ureteral stricture following circumferential burn in the ureter is the risk factor there. So this is a video from my friend, Dr. Filipino from Brazil. So they had a polypodal mid-ureteric tumor measuring around 2 centimeter. It was a solitary kidney. Initially, they have done a cup biopsy, which was a low-grade tumor. Then they gone in after 15 days with access sheath of 12 or 14 French post-tented with 6 French ureteroscope. And they have used a 500 micron laser fiber with a setting of 0.5 joules and 50 hertz. And they were able to ablate the tumor completely up to the base. So main criteria or the technique here is you should always do like the stone. You have to start from the center. Automatically the volume of the tumor reduces. Once the charring has been formed, then you can slowly bit by bit, you can excise the char, and access sheet definitely helps you in getting those fragments or the tissue bits out whenever required. You can use a handheld syringe where a person assistant will know with what pressure he has to use. Otherwise, this reduces your visibility and the chances of complete resection will be less. So once they have done this, They have done 2 times the same procedure over a 6 weeks period. And then this is the last 6 months follow-up cystoscope and the rigid ureteroscope. I was surprised to see this video. The complete tumor has gone and there is no stricture in the ureteral wall, and there is no tumor seeding either in the kidney or anywhere else. They have done the check ureteroscopy and cystoscopy also. So definitely endoscopic management, if it is a low-grade tumor, has a definite advantage for selected patients, not for everybody. So what does the literature says? So whoever undergone the biopsy subsequent, they have undergone upper tract tumors, 90% were correctly diagnosed with a low-grade and moderate-grade neoplasm, and 91% had a high-grade tumors. So this indicates that upper endoscopic management is feasible. So overall oncological outcome, this has been a review article from which I have taken few points, which will be take-home messages like grade 1 tumor has the best prognosis, disease recurrence rate is 5 to 20%, progression is likely with higher grades, and chances of deaths are very, very, very rare. Grade 2 prognosis is variable, recurrence rate in 99 patients from 7 series has been 21%. In 4 to 5 studies where disease-specific survival was reported, could be calculated in grade 2 pathology, died of cancers are very, very less than 5%. So grade 3, no question, prognosis is of a high grade, the high stage upper tract disease is poor, regardless of the management modality. In the largest published series, the recurrence rate is 56% and 64% disease-specific survival. One more important point in any endoscopic management of either the bladder or the ureter or the renal pelvis is adjuvant therapy, where we use BCG, mitomycin, epirubicin, or thiotepa. There is no specific guidelines, specific dosage, specific treatment modality, how we are using it. As a primary tumor, carcinoma in situ, and adjuvant tumors, adjuvant therapy following resection has shown a good response. Topical therapy and chemotherapy has been delivered. Either you can use a retrograde installation by ureteric catheter, place a stent, there will be a reflux, or use a pectoral nephrostomy tube. So response rate for BCG in upper tract carcinoma in situ defined as a normalization of a selective urine cytology has been seen up to 60 to 100%, but not defining in terms of cancer-specific survival or overall survival. Recurrence rate following adjuvant therapy is 30 to 60% with a follow-up of 50 to 60 months. So overall, due to this technological advancement and refinement in endoscopic techniques, most of these low-grade tumors can be treated with an endoscopic method. Percutaneous method gives ideal indication for a large bulk tumor, low grade, or a solitary kidney where you can meddle into the renal pelvis, especially the lower calyx. Ureteroscopy initially to treat the primary lesion along with the upper tract lesions, provide the procedure is technically feasible. Role of BCG in the treatment is not demonstratively effective, but definitive efficacy of adjuvant topical therapy following endoscopic resection for primary tumor has not been shown. So in a patient with a functional or a solitary kidney, conservative endoscopic management of even a high-grade disease delay the stages of nephrectomy. That is the only added point. If you have a single kidney at the high-grade tumor, very small lesion, we can delay their nephrectomy, we may not be preventing it. So long-term follow-up and regular surveillance is the key to go there. Thank you, one and all.
So thank you so much. We'll take the questions after the last talk.
Sure.
Just one comment.
Yes.
Everything you covered. Before giving any adjuvant therapy, after you've done endoscopic resection, you should always mention and do a RGP. Because
Sure,
if there is
sure.
any perforation in that, then you
Then
have
we
to
can't
take
do
care
that.
of that. So
Taken, sir, taken.
So now I'll invite Dr. Indranil Banerjee for the next talk. He's speaking on lymph node dissection in upper tract TCC. How important, what is the evidence on that?
Good afternoon, everyone, and thank you organizers for the invitation. I am going to talk about the role of lymphadenectomy, which is often underutilized in this space. We all know that we have 3 important components in upper tract TCC management, that is nephroidectomy, the bladder cuff, which we have already covered, and the third one is the lymph node dissection. I have no conflict of interest. So this is the agenda of the talk. So I will start with the limitation of my talk. My talk is based on a rare disease, which is based on retrospective multi-standard studies. So the level of evidence is low. And regarding the template of dissection in lymph node, there is no consensus. What about the benefit of lymphadenectomy in ureteric tumor, which is in the lower ureter? What about lymphadenectomy in node positive patients, clinical node positive patients? And neoadjuvant data in node negative patients is maturing. So just to give a background, lymph node metastasis in upper tract TCC or urothelial tumors is an independent predictor for lower survival rates. And as we got the POUT trial, that if we have lymph node positive patients after surgery, they benefit with adjuvant chemotherapy. So that lymphadenectomy has a prognostic benefit. What about the curative role? It is controversial. But retrospective evidence support that lymphadenectomy for all patients who will undergo radical nephrorectomy benefits from this. But unfortunately, in a Canadian study, it has been proven that only 27% of the patients who undergoes lymphadenectomy who undergoes nephrorectomy has a simultaneous lymphadenectomy. Again, the same slide from the previous speakers, but we will consider the high risk urothelial tumors because these are the patients which we see in our practice mostly. If any of these factors are present, then these patients most likely need a nephrorectomy along with lymphadenectomy. So as for the EU guidelines, it should be done in all patients where we are planning for nephrorectomy, which are non-metastatic and high risk. And it has been shown it improves the cancer-specific survival in patients who are more than T2, and it reduces the local recurrence. And it improves the survival even who are pathologically node negative after lymphadenectomy. What about node positive disease? There's a recent study published in May 2022. It has shown no benefit in patient who undergoes lymphadenectomy in overall survivals, and that is same in all D stages. So in node positive disease, upfront lymphadenectomy is not recommended as of now. So quickly go through the principles as per the Kondo studies. Primary site of lymph node mets depends upon the primary tumor location. If it is above the common iliac artery, the tumor location, then it doesn't usually cross. And if it is in lower ureter, then it seldom goes above the aortic bifurcation. If it is in right renal pelvic, right upper ureter, middle ureter, it usually goes to the hilar, paracaval, retrocaval, and intercaval lymph nodes. And the left side, it usually goes to the para-aortic and hilar lymph nodes. And if it is in lower ureter, although there are case reports of rare mets to the para-aortic lymph nodes, but usually it goes to the pelvic lymph nodes. Based on that, this is the suggested template as per the Kondo's paper. If it is a renal pelvis on the right side, we can go up to the inferior mesenteric artery. On the left side, the same thing. But if it's the upper 2/3 of the ureters, then we have to go up to the aortic bifurcation. And if it is a lower 1/3, then the both side, we have to do ipsilateral pelvic lymph node dissection. What about the quality control? How many lymph nodes should be removed? At least 8. And there's a paper of lymph node density. If it is more than 30% of lymph nodes are positive, then the chances of cancer-specific survival decreases. Now, about the surgical approach. So there's different ways. How can you peel a grape? You can use your hand. That is open surgery. Or you can use a stick to peel the grape. Or you can use a robot to peel the grape, which is more precise. So you can use all of these 3 approaches to do a lymphadenectomy. But what does the evidence say? Again, the evidence is not robust because most of these are large retrospective studies. And it has been seen that if the patients are undergoing robotic radical nephrorectomy, then they're most likely to undergo lymphadenectomy as compared to open and lap. And those patients in all the groups have lymphadenectomy has more complications. Intraoperative complications were same in all the 3 approaches, but postoperative complications were less in the robotic group as compared to the open group. Mind you, it's a retrospective data, and most of the complications were related to the blood transfusion, bleeding, and postoperative ILS. This is a port placement on right and left side in XI robot. In XI, the advantages are it is a linear port placement, and we just can hop the camera down by one, and use the same port configuration without need to redock. But if in the SI, Dr. Kinju has shown a different kind of ports configuration, you can use that. But in that case, you have to redock. And this is the port placement which is usually preferred by Dr. Jim Porter from Swedish Urology. He placed the camera more laterally. And I don't know where is the pointer. So this is the camera. And then he can do this is the right sided nephrectomy, head and feet end. So he can do this 3-port configuration, the nephrectomy part, and the robot comes from here. Then the robot goes here, and this is the camera port, and he will use this 2 ports for the bladder cuff and lower part. So this is a video. This is not my video. This is Dr. Jim Porter's video. So you start the right sided temporal lymph node dissection. You start with the ureter dissection first. You clip the ureter, then you drop the duodenum. Try to identify the major vessels, the IVC, and you just march along the anterior surface of the IVC. And it's important that you clip the ureter early so that there is less spillage, and also the artery is clipped and divided so that you go high up to the hilum. Either you can use the bipolar cautery to coagulate the lymphatics, or you can use the clips. Using the clips may prevent postoperative lymph leak. And gradually you march towards the hilum, following the anterior surface of big vessels. This is the IVC. You go beyond the IVC to dissect the entire trocaval package. It's a split and roll technique. And all the big lymphatics should be clipped. So once the packet is released from the hilum, you march downwards. And this is the renal hilar area. Arteries are already been divided. Then you have to leave this packet, free it completely. So you have to be close to the renal artery so that all the lymph nodes are removed. And then you march downwards towards the aortic bifurcation. And right side template dissection is then done. I quickly show the left side, again from the same surgeon, Jim Porter. You divide the renal vessels. On the right side, the advantage is you see the IVC first, so you are simultaneously doing the lymph node dissection and also the hilar dissection simultaneously. But in the left side, it's always preferable to complete the nephrectomy first, so that you are able to see it much better. The aorta and the para-aortic lymph nodes are seen better if you do the nephrectomy first. So here he is completing the nephrectomy. And once the nephrectomy is completed, that you get more space and you just march along the anterior surface of the aorta and clip the bigger lymphatic vessels. And for the lumbars, you can either clip it or use the bipolar to coagulate it for the lumbar veins, but the arteries, you need to divide those. And that way the left-sided lymph node dissection has been completed. So the take-home message will be, if it is a pathological node positive, is present in clinical node positive patient, if it is more than T2, around 14 to 40%. So there's a recommendation, any patients more than T2 and higher should have a lymphadenectomy done during nephroterectomy. Lymph node dissection improves tumor staging and possible adjuvant chemotherapy as per the POUT trial. And it improves the cancer-specific survival in PT2 patients. In the renal, pelvic, and upper uteric tumor, we don't have the data in the lower uteric tumor as of now. And lymphadenectomy should be as per the anatomical template. Thank you.
Thanks, Indranil, for your wonderful talk. I would ask our experts to opine on this.
Thank you, Indranil. Just a couple of comments. This lymph node dissection, as you rightly pointed out in the end, is mainly beneficial for clinically node-negative PT2 tumors, and it has been seen that it is more beneficial for renal pelvic tumors rather than lower ureteric tumors. And doing a template-based lymph node dissection helps rather than doing a lymph node dissection which may be extensive. Taking out more nodes does not help in that in reducing the recurrences as compared to doing a complete template base. So template base is required, and like you pointed out in lymph node yield 8, that is a very controversial topic. So 8 lymph nodes does not help. So even if you're removing 40 lymph nodes and not doing a template based lymph node dissection, there is higher chances of recurrence as compared to just removing maybe 20 nodes and doing a template. Secondly, robotically, because of the ergonomic, because of the ease of dissection, it is more common that we do more lymph node dissection as compared to laparoscopically, and that has been the reason of improved probably survival and more lymph node dissection. You want to add?
Yeah, the other technique you mentioned is you can do, like the video you showed, you can do the nephrectomy and then do the lymph node dissection. What I found is along with the nephrectomy, if you go along the vessel and do the lymph node dissection, because there's a traction of the kidney continuously, so you can do the lymph node dissection. That is just a personal experience.
So right side, I think, is easier.
So
left side is sticky.
Yeah, one more thing is that you pointed out also, whenever you are doing radical nephrectomy, lymph node dissection has to be done, because this is mostly we are doing for higher grade tumors. Now, the literature says that it is helpful for PT2 tumors, but there is often scenarios when you don't know whether it is baby. Once you remove that, you will know only at that time. So you are removing the lymph node at the surgery itself. So you have to have some predictive prognostic markers which will tell you that these are PT2 tumors. And so, like in the last talk, for lower grade tumors, you may have endoscopic treatment, but whenever you are doing radical nephrectomy, you have to do a lymph node dissection, and not thinking that this may not look as PT2 on CT, so you can skip. So you have always to do lymph node dissection.
Yeah, if it's T3, T4, anyway, they will receive adjuvant chemotherapy.
Yeah.
Thank you, sir.
Just one comment on the endourology management, not for you, Indranil. So there is now the trial, Olympus trial, which showed the mitomycin gel, which can be weekly instilled 6 weeks, like what we give mitomycin in bladder sometimes. So that has also showed a decent response, not a great response, but 1 year is almost 60–70% recurrence-free survival. So that is one more option if it comes in India.
Yeah, so that the basis for that is actually because the gel is more helpful because it's a thermosensitive thing. It's liquid at room temperature and it becomes gel when you put it in the, so it is retained more up to 90 minutes. So that is why it is helpful.
Regarding the bladder cuff excision, generally it is recommended you instill mitomycin within 7 to 10 days time. to prevent any local recurrences happening. So prior to that, just confirm with the cystogram that there is no significant leak.
Any comments on segmental uretrectomy?
Segmental uretrectomy is not recommended for upper ureteric tumors. So in solitary kidney, there are case scenarios where they have mentioned that ileal replacements have been done in solitary kidneys. But with other normal functioning kidney, for distal, you can do it. What Shrikant showed the video, I think one of the good techniques.
Okay, thank you. I congratulate all the speakers for their very nice presentations, and also thank our experts for the expert opinions. We close the session. Thank you.
Next, we have a crossfire session. I'll request moderator Dr. Rohit Joshi sir to come on the dais and then introduce the chairpersons and start the session, please.
Good afternoon, or I say good morning. There have been monologues and there have been dialogues. So I was speaking to Lakshman. The dialogues always fetch little more attention than monologues. So we have seen a lot of monologues. Now is the time to go for the dialogues. So Abhijit, are you there to help me with my slides? Not this one. The fifth one, down below. Thank you. So friends, a warm welcome to all of you to the third edition of this Youth Conclave at Hyderabad. And let us first acknowledge the whole USI Council as well as the U Council for having given us this opportunity to entertain you guys with this kind of a dialogue. And why I call this as a dialogue, because this is a session which is named as Crossfires. Can you make it full screen for once and all, sir? Please. Yeah, next. So it's a war zone. And so what my role will be to have a kind of a peacekeeper between the debaters who will debate on certain scientific agenda. And we have got no problem with them debating, because ultimately we need to take home a message which helps us in treating our patients in our setup according to the situation where we and our patients are in. So first debate was which laser to buy for a beginner in endourology. But the first question, any beginner, if I would have been a beginner, I would ask, do really I need to buy a laser? Let's see why. Because the scenario is changing very fast. Every year 350, 400 urologists are coming out. So the pool is ever expanding. There is nothing can limit that. Enormous work is being done at peripheral. Tanuj was talking to me, there are 4 urologists in Sonipat now. So simple cases stop working in our setup if we are in a metro city. So all those cases which refer to us are all demanding cases. Secondly, patients have become really educated because of the electronic media, print media, Uberization, personalization, whatnot. At times, they know better than me. Whether they deserve a prostatectomy or not, that's the second question. But they will come and tell, sir, mujhe laser karwana hai. So these are the things which leads us in kind of a race where there is a survival of the fittest. And that's why we need to add versatility, not just to our skill setup, but as well as for our endourological armamentarium. And that's why probably as a beginner, I'll answer, yes, we do need to buy a laser. Now, whether to buy a holmium laser or a thulmium laser. Since holmium is a couple of decades senior to the thulmium fiber laser, let me give the first opportunity to my friend Tanuj. Tanuj, please come forward. But before you come forward, let me invite my dear friend Pankaj Maheshwari and Saeed Bin to join us on the stage. They will be our chairpersons for the expert comments later on. Over to you, Tanuj.
Thank you, Rohit sir. Thank you, you and USI for this opportunity. Can I have my slides, please? Yeah. Yeah, so I will try to answer this question for the beginners, that which laser to buy as a beginner, and I would be talking about holmium. So as Rohit sir rightly said, and I will also take up that question. But first, let us understand these technologies. We are debating today holmium versus thulium, which happen to be neighbors on the periodic table, but they are fighting like usual neighbors. So about holmium laser, we know that there is a cavity in which there is a holmium doped YAG crystal, which is when a flash lamp is fired and photons are generated, which bombard inside the cavities and they come out through an aperture. What happens during this process is that some amount of energy is wasted. That's why there is a lot of heat generation in holmium lasers, and that's why they need bigger water cooling systems. But now there are lightweight cooling systems as well. A low power laser would generally have a single cavity, and a high power laser would have multiple cavities, and that would determine the energy that can be used with those lasers and the frequency they can go to. These lasers have cavities, and they have mirrors which require alignment. So external shocks should be avoided for holmium lasers. Otherwise, there can be misalignment and issues. Regarding thulium fiber laser, the energy source is diode laser, which fires into a long silica fiber, which is doped with the thulium crystals, and you get a 1940 nanometer laser beam. And these are the characteristics in the first few articles which came out. And you can see that with the thulium fiber laser, we have a much wider range of energy. We have a much wider range of frequency, with frequency going as high as 2200 Hertz. And we have a much wider pulse width. But we have to understand, with greater power comes great responsibility. And this is what the makers of thulium fiber laser forgot. So coming to the question which Rohit sir has also addressed, does a beginner need a laser early on? My answer to that is yes, definitely yes. Why? It is the need of time. Why? Because you will have a patient who is a well-informed patient, and he will come and ask you for an RARS. Now you can do a URS without a laser. You can do a PCNL without a laser. You can treat a prostate also without a laser, but you cannot do a RARS without a laser. So it is the need of time. We need to have that technology in our armamentarium. And very importantly, we have to be loyal to our patient. When we say laser, we have to do laser. The patient comes and says, Doc Saab, can you operate my prostate with laser? And you do a TORP. That's not fair. If you're saying laser, do laser. So what are the things on a beginner's mind? That's how I would like to go about this debate. Number one thing is the finances, the initial cost of buying the laser, the recurring cost of the laser, the payment options that he has. Number two is reliability, whether he can rely on this machine for his day-to-day use. Number three is versatility. What all can actually the urologist use the laser for? Number four is portability, which would be on the mind of a roaming urologist. Number five is durability. How long is the laser machine going to last? I'm investing so much amount of money. When will I have to invest again? And number six is need and availability of service. This is very important. And number seven is return of investment. So let's take this one by one. So first, let's talk about the finances. If you talk about the low cost laser, the low power lasers come between 18 lakh to 35 lakhs. Now this is unbeatable. No thulium fiber laser you can get for as low as 18 lakh rupees. And high power lasers can cost you anything between 45 lakh to 1.8 crores. Regarding the recurring cost, yes, there is a cost of the fiber. Most of the fibers cost between 20,000 to 50,000 rupees. And there's the cost of blast shield, which is about 10,000 rupees in some machines. So thulium fiber promoters, they always project this as a major expenditure, but actually it prevents your expenditure because the blast shield, it protects your mirrors inside the machine. And those are the costly repairs. So blast shields are actually quite worth. Now there are ways to decrease the recurring cost. Number one, have your technicians trained in laser care. Reduce the movement, reduce the collisions, maintains the alignment of the mirrors, and you should always have routine check of laser fiber and blast shields. I'll just skip this. So coming to reliability of lasers, now holmium YAG has stood the test of time. It has been market leader since 25 years, and most used laser for lithotripsy as well as prostate as of now. And if you see the projection, there is a projection that by 2026, which is the pointer, yeah. So there is an ever-growing market, but we can say in the projection also there is an equivalent share of both the lasers. But yes, most commonly they are used for lithotripsy and prostate. Now let's look at the publications. Now, being one of the oldest lasers, it is the most used and most published as well. But let's not go back to years ago. Let's look at just this year. Within this year itself, till now there are 461 published papers on holmium laser. And if you look at the same data for thulium, it's only 80 papers till now. So definitely there are much more robust data available in literature in support of holmium lasers. Now, one of the reasons for shift towards RARS, like this graph is quite popular over the years. The ESWL has gone down, RARS has gone up, PCNL has remained stable. And one of the main reasons behind that is the popularity of and availability of holmium lasers for all stone locations and all compositions. Now coming to versatility. If I am buying a laser, what all can I really use it for? First of all, most commonly, we like to use it for URS, which is the most common surgery done in a routine practice, but there is a certain way of using the laser in the ureter. This holds true for both the types of lasers. You have to fire in the center of the stone, you have to make bigger pieces, and you have to take out the pieces. Now, this is where the problem with thulium fiber laser lies. It's more of a duster than a fragmenter, and generally you will be creating more dust inside the ureter also. And for that, you might have to go close to the ureteric wall. And we know that there are temperature issues and we are scared and we don't want to have a stricture later on. But yes, it's commonly used for URS. And a holmium laser quite safe for URS. We know there have been multiple papers regarding safety concerns over thulium fiber laser. Initially, there have been reports of supraphysiological ureteric temperatures. And also there have been papers which have told us how to make it safe. So what they recommend is either you use low energy or you use moderate irrigation. Now it's fine to use moderate irrigation, but we know that in ureteroscopy, whenever we are using moderate irrigation, that means we are increasing the risk of sepsis, we are increasing the risk of perinephric collections and so on. So we have to be careful because our patient safety is in our hands. Now, the next commonly done procedure with lasers, of course, is RARS. We can see in these videos that we can do very good dusting as well as fragmentation with holmium laser. Whereas with the thulium fiber laser, it's more of a duster, as I said. It is definitely a bit faster when compared to holmium we have seen when it comes to dusting. But when we want to fragment the stones, for example, there is the 8 mm stone. I would just like to make 3-4 fragments and basket it out. Now, also we can drill into the stones and pick them up very easily with a 200 micron laser fiber. I have heard many times users of TFL being a bit scared of doing this because I don't know whether the company has told them or what, but they are scared of the laser, some of the energy going back to the machine, damaging it, I don't know. But we do it commonly with holmium laser without any scare. And even if the fiber gets damaged, the blast shield is there to save the machine. Now, there is a 150 micron fiber available with TFL. That's why they say you can go to any location. Now, this is a case which I've done just day before yesterday. And this was a horseshoe kidney, salvage RARS for an infundibular stone. And you can see how comfortably, easily I could reach that location with a 200 micron fiber and fragment the stones there. So these cases are doable equally well with a holmium laser as well. You don't really need a 150 micron fiber, and we don't really know whether a smaller fiber than that will come or not. Now, next commonly done procedure is mini PCNL. I feel holmium is much better for mini PCNL compared to thulium because, again, we want fragmentation here. We don't want dusting. So we quickly make multiple fragments and just pick them out and give complete clearance. When I'm doing a diverticulotomy, I feel very safe with holmium laser because I know there is not much collateral damage happening around. So there won't be any infundibular stenosis or the scarring in the calyx. Similarly, for endopulotomy, again, I would always prefer a holmium laser compared to a thulium fiber laser because I want a nice clean cut without any charring. So again, that can be done with holmium very nicely. Of course, for laser prostatectomy, we can see how nicely we can enucleate with the holmium laser. Also, if we have to do hemostasis, nice pinpoint hemostasis can be done, as can be seen in these two videos. And as we are doing the procedure, very nice plane is dissected without any charring. Now, these two videos show a thulip, ongoing thulip, and we can see that there is, despite being in the right plane, there is some amount of charring happening there. It is an issue. And that's mainly because you have to be really close to the tissue when you are enucleating. And also point hemostasis is a bit difficult and capsule is not clearly visible. Now, this is a fossa at the end of Conclave and Hulep. The only variable here is the laser machine. The surgeon is same, the instruments are same, only energy source is different. And you can see the fossa of Hulep is much more cleaner and nice white compared to a Conclave fossa where you can see some charring. Now Hulep is accepted as a gold standard. This is many papers are there regarding this. And also there are so many other things, like we can use it for a ureterocele incision, a posterior urethral valve, OIU, and so on. And there are changes coming up in holmium laser machines, which are making them more and more user-friendly. Portability, yes, is an issue with holmium laser machines. That's mainly because of the alignment of the mirrors and the cooling systems. They are heavier machines, and that is one place where the TFL does score. Durability, I would say I'm a proud user of holmium laser machine. Same machine since 7 years, no major repairs so far, no sudden shutdowns, and machine has auto testing in the start. So even if it shows an error, you can just call the service guy and he'll help you resolve it then and there. Service is not an issue with most of the holmium laser machines. They provide service within 24 hours by most of the major companies. Spare parts are easily available. Extra fibers and blast shield can be kept in the department and changed by in-house biomedical team itself. AMC and CMC options are available. Now coming to return of investment, of course, having a versatile laser at hand aids in getting a return of investment, because then you would use it for so many indications. It is the preferred laser over lithoclast. Yeah. Is a preferred. Okay. So Hulep is feasible for any size. It does give an edge to the department because it has a branding opportunity. Good results and safe treatment means a happy patient. Thank you.
Thank you so much, Tanuj, for the elaborative talk. There is no rebuttal, so I would welcome Saeed to please come forward. Your job is made easy by Tanuj. He spoke about basics of Thulmium. He spoke about technologies. So over to you now.
Good afternoon, everyone. We just heard the master deliver his talk on holmium machine. It was a very impressive talk, Dr. Tanuj. Before I put my point across, the same thought comes to all the young and beginning urologists who want to start laser surgeries, is whether you want to buy a laser or not. So it's a classical case of chicken or the egg situation, which came first. Now, there are a lot of people who believe that you need to develop practice. You need to have a patient base before you invest into a particular investment, because it's a huge investment, not a small investment. Now, I, on the contrary, feel that laser is a must in our armamentarium. Now, I am vouching for the thulium fiber laser. What we have to understand that the thulium fiber laser is not the same as the thulium YAG laser. Thulium fiber laser is a pulsed laser, whereas the thulium YAG laser is a continuous laser. Now, there are many machines available in the market for the thulium fiber laser, and with varying degrees of certification. Now, as Dr. Tanuj mentioned, that holmium has been used since a long time, and it's still the gold standard. It's been used since 1992, but this is the new kid on the block. And there are number of publications which are increasing day by day, comparing both the technologies. Now, Dr. Tanuj has already mentioned the physics of the laser, whereas compared to the flash lamp laser of the holmium, the thulium fiber laser is a diode laser passing through the thulium doped silica fiber. Now, what to understand? Before buying a machine, we need to understand certain characteristics or certain features of the laser machine, which will help us try to understand why we need to buy that particular machine. So, pulse shape and width, the peak pressure at the start, the energy, the frequency, and the total power. Now, this tabular column comparing both, you can see that the pulse energy is 0.2 to 6 joules in holmium, whereas it's as low as 0.025 in case of thulium fiber laser. The maximum pulse frequency is about 120 hertz in holmium laser, and it's about 2000 hertz in case of thulium fiber laser. And also the pulse duration range, it varies from 0.05 to 1 millisecond, whereas it's 0.05 to 12 milliseconds in case of thulium fiber laser. Now, this is water absorption coefficient. It's 4 times higher in thulium laser as compared to holmium YAG laser. Well, now, what does that translate into? It translates into lower threshold and higher ablation efficiency, and also lower tissue and water penetration depth. This is a temporal beam. On the left side of the screen, you can see a pulse shape of a thulium fiber. It is very symmetrical, and it has very low peak power at the beginning. Whereas this is a typical shark fin appearance of the holmium fiber, where pulse, wherein it is there are irregular energy spikes. Now this is at the output. Now the holmium energy is delivered at around 300 micrometers in diameter, and it is very erratic as compared to the thulium, which is about 70 micrometer, which is very concentric and smooth. Now this translates into utilizing this particular energy to produce this particular energy with utilizing a very low diameter fiber or less diameter fibers, which is not possible with holmium. Now, what to expect? The majority of the beginners will have stone disease as their chunk of their practice. So with respect to the stone disease, what to expect is the speed, the retropulsion, the safety, the fibers, and the maintenance. Now, TFL is capable of producing twice as much as dust as compared to the holmium laser, even with MOSIS technology. I think Dr. Tanuj agreed with that. And it has significant shorter total operation and laser time. Now, by dust, I mean it has to be very fine, because we are already in terms, we want to suction out the dust which is produced. And for that, we need very minute dust as less as 200 microns, which can be only possible with the thulium fiber laser. Now, retropulsion, it's 3 times lesser retropulsion as compared to that of the holmium machine. So again, thulium fiber outscores holmium fiber. And as far as the irrigation is concerned, because of the fear of retropulsion, probably you might not use that adequate irrigation, and your vision might be hampered, especially in the ureter. Whereas in thulium, we are not worried about retropulsion if we know how to control the frequency and the energy, and we might use a little more energy for our liking and to improve the vision. Now, there's a lot of talk about safety, but I would like to quote Dr. Oliver Traxler in his recent talk. He said that it is not the technology which is at fault, it is the way we use it. So if we keep the frequency low and the total power low, I think that it is a very safe machine to use in the ureter as well. Now, coming to fibers, we all know that the lesser the fiber size, the more the irrigation, more the irrigation, and the vision is better. And also Dr. Tanuj just demonstrated a case which he did with ease, with which he could go to the lower calyx. But what we have to understand is the more flexion or deflection of the scope, the chances of the fiber breaking in holmium is far more higher as compared to thulium. If you go a little more than 0.8 mm, that is the data which says that you can't go a little more than 0.8 mm. And the damage thresholds, if you consider 200 micron fiber, what is recommended is 25 watts of total power, which can be used in holmium fiber, whereas it's up to 80 watts in thulium fiber. Now, maintenance, it's a very low maintenance machine, the thulium fiber laser. The reason being, there is no water cooling system required. It's just a simple exhaust fan. There's no blast shield effect, like what Dr. Tanuj already has said. Less fiber burn, and it is more environmental friendly. That it is 10 times more environmental friendly than that of the holmium machine. Now, soft tissue application, if you want to enucleate a bladder tumor, what properties are you looking at? What you expect from a laser is the hemostatic property, whether it enucleates completely with no bleeding, and whether you get the muscle in your specimen, and the tissue penetration is low. All these 3 factors are easily achievable with the thulium fiber laser. Now, standard PCNL, yes, I would agree that definitely there is a role for bigger diameter fibers wherein we need bigger energy. But for mini perk, for about 2 centimeter stone less than 2 centimeter size, I don't think you require a high energy or a high power system. A 60 watt thulium fiber laser is more than enough. Now, this is a famous, I think all of us would have gone through this paper by Dr. Thomas Herman, where he emphasized on the technique of enucleation with different, only the energy changes remain, I mean, the energy changes, energy sources change. But what we have to understand as a beginner, what is the emotion that we go through when we hear the word enucleation is fear. The reason being, we are not, as beginners, we are not very well versed with this particular technique, and we'll have to start from the scratch. And why the fear is the risk of losing the plane in holmium, especially for beginners, wherein we'll not be able to complete the case. So I always relate this to the Chakravyu from the Mahabharata, wherein a urologist's life also can go into Chakravyu if you lose the plane, and you'll have to be an expert to come out of the situation like this. Whereas for a beginner, you can still do a micro enucleation and then complete the case. And a lot of talk about charring. Charring does not have any significance as such, but as you do more and more cases, you can utilize it to your benefit. As you can see, yes, it chars, but the adenoma chars a little more than that of the fibers. The fiber still remains a little whitish. So there is a difference. So you can stay within the plane. As far as the fossa is concerned, it all depends on your experience. The more number of cases you do, you will get a beautiful fossa, and the outcome is very good. So now this is a picture which all of us Indians relate to. We always ask for a mileage, but this is not a miserly attitude. It is more value for money. We want something in return for whatever we invest in. So the cost benefit ratio is purely a bad score for the holmium machine. Now, another important thing is, like Dr. Tanuj has already said, it's a portable machine. We can take it to wherever you want, especially for a freelancer. Now, recently, one of my friend had a breakdown of his holmium machine, and then he gave me a call saying that, Zahid, can you please help me out? And I sent my machine to him, and then he could complete the case. And better reach of technology, we fail as a society if we do not ensure that this particular technology of laser, be it holmium or thulium, does not reach to every nook and corner of our country, which is not possible with holmium because of many reasons, whereas the thulium, it is still possible. Now, this is a picture, both photographs taken by me, that initial days of my photography, and this is the most recent one. Now, what I want to put my point across with this is, not just the machine, the man behind the machine is important. If I give my 60-watt machine to Dr. Tanuj, I'm sure he will do a far better job and equally good job as he does with his holmium. So why do you need a holmium machine? Thulium is enough. Thank you.
Thank you so much. Before we come to any conclusion, let me ask Pankaj. Pankaj, what is your take? You've been using holmium like me for the last 2 decades. What's your take on this?
So Dr. Raza, I'm sorry you have an extremely biased umpire here. Friends, as I have been with holmium laser for nearly 2 decades, and I would say that the distinct advantage that holmium laser gives you as far as HOLEP is concerned, the plasma dissection that you get with HOLEP is definitely not possible with thulium fiber because of the extremely low fluid coefficient. You need to nearly go and touch the tissue before you cut the tissue. So if you are really aiming at treating prostates which are larger than 100 grams, then probably holmium laser is the way to go. Otherwise, for smaller glands, thulium fiber would work as good. Again, as far as stone is concerned, yes, thulium fiber is really giving a tough competition to holmium laser as well as stone lithotripsy is concerned. As far as I am concerned, I am still a bit, say, apprehensive about using thulium fiber in the ureter. I'm still afraid of the high temperatures and the risk of strictures. So yes, this is probably the technology of future. As of now, holmium laser scores. Thank you.
That was really modest of you, Pankaj. Yeah, but Z, I congratulate you. You selected me for this because I have an access to holmium 100 for last 12 years, and now I am having Thulmium. So what we do is, these are my take-home message. If I want to tell you something, for stones, TFL has definite age. Time is there, although it's a new one, but time is come that, all agree to this. The second statement, which I can say is for EEP, mind well, holmium is a butter knife, while TFL is a cutting knife. That's single line message. You will all take it that way. So whenever you are converse with the holmium thing, you will find it very difficult to, transform yourself into thulmium. But if somebody who is not into holmium, thulmium enucleation will be far, far easier. So thank you so much, gentlemen, for the debate. Now moving to the next crossfire. Again, my role as a peacekeeper. Now the question is fellowship after residency. Now there are two options: structured long-term or a focused short-term. Let's see a journey. Any guess who is this fellow? Yep, you got it right. He just cleared 12th examination with straight rank. Proudly got admission into MBBS. Bada uncha collar rakh ke ghumne laga. Then he cleared MBBS with a distinction. Again got admission into MS. Cleared MS with a gold medal. He felt like a king. Then he came to the reality. Then he became an MCH DNB in urology. And then he felt Mehu Dawn. And right at that moment that, he and I were feeling like Mehu Dawn, he struck. Hey Rohit, who are you? Are you a Dawn? No, for me you are Nod. What do you mean by Nod? Not obviously detectable. Because what you are a general urologist after doing 30 to 33 years of hard work, like spending 33 years of your life, 15 years in pursuing urology, what you become is just a general urologist. Now is the era of subspecialty. So that day my world came crashing down, and that's where the new journey began, from a Dawn again to the Nod. So now let us hear from two of our very esteemed colleagues. First of all, let me ask Deep Jain to come forward and put his point across for a structured long-term fellowship. Over to you, Deep.
Good afternoon, everyone. Thank you so much, USI and YOU, for giving me this opportunity to talk on a topic which I feel is very dear to me. Fellowship after residency, a structured 1 to 2 year program, which I'll be talking in favor of. I have no disclosures. So I'll be covering the topic under the following headings: a brief introduction of what the term fellowship stands for, what fellowship options do we have, what are the platform and resources where you can access and get information regarding these fellowships. How do you go about making a decision whether you actually should need to do a fellowship, what fellowship, where to do, when to do. A short few slides on what my life was during my fellowship. So when we talk about fellowship in the academic setting, it by definition means referring to a monetary award given to a scholar to pay for his or her academic pursuits. So in other words, it's a merit-based scholarship for advanced study of an academic subject. But what we are looking for is that a fellowship program offers you a career development opportunity. It provides you with experiential training, and it can be used to recruit personnel to address specific challenges facing the public health workforce. Fellowship is a means to become socially committed agent of change. It helps you become effective networker and facilitator. It makes you capable of engaging into self-assessment, self-reflection, and analysis. It makes you committed to the lifelong learning of themselves and others. It makes you understanding of environment, social, and economic connections. It gives you the ability to act as a responsible citizen. It makes you a critical and system thinker with the ability to solve problems creatively. It makes you work in cooperative environments and with others. It makes you proactive, not reactive. And it makes you enthusiastic, passionate, and inspiring. So when you come to options, what do we have? We have obviously clinical fellowships, and let me not see the importance of research fellowship. I think people are losing the importance of research fellowship. People should be equally enthusiastic in opting and searching for research fellowships in different parts of the world. So coming to the various options and resources that we have where we can look upon and search for fellowships. We'll start with the Urology Society of India, which is actually in the developing phase, where we are making a page where various subspecialty fellowships in the country will be uploaded, and mentors are going to be allowing all the upcoming residents to choose the fellowship through the website. And this is still upcoming, but it is going to be a very demanding thing for the upcoming residents. So when we search, if you are looking for a fellowship opportunity in the UK, obviously you need to go to the NHS website, wherein the regular feeds for all fellowships and residency programs at the UK keep coming every week. There is a list of advertisements that that they have coming in, and you need to make a account in the NHS jobs website. Be also, you'll have to enroll into the track jobs website, wherein the eventual filling of the application forms is done. You have to also apply to the email notification services, wherein every week you get a mail from them regarding what new job fellowships are available in the UK. Then we have the European Association of Urology, which also has many fellowship options, which include a one-year scholarship, clinical visits, and in the fellowships, they have a kidney transplant, endourology, uro-oncology, and fertility fellowships. But you need to be a EAU member for this, and also there are some certain terms and conditions for each of the fellowships which you need to go through when you go to their website. In US, as far as the uro-oncology fellowship is concerned, you can go to the website of the Society of Urologic Oncology, wherein you can find a fellowship section where they have listed all the approved programs across the US for uro-oncology fellowship. But you need to give the USMLE exams even to apply for even research fellowships in the US, because the mentors over there preferably want you to at least clear the USMLE before you apply for any clinical or research fellowships. Also, social medias, we are regularly using Facebook and Twitter as medium. So you can search for fellowship applications and invitations on the Facebook as well as Twitter. You can approach all the mentors through the Facebook and Facebook messengers and Twitter, and convey to them you are interested in so and so fellowship, and approach them every time from time and again, so that they are convinced that you are genuinely interested in pursuing a fellowship. Then and only then will they consider, because you need to be persistent when you apply to any of the mentors. You need to show persistence, and you need to show hard work that you are really interested in that particular fellowship. So how do you go about making a decision whether you should actually pursue a fellowship, and when and where to do it? So this will start when you start reflecting upon yourself during residency. We all have unit rotations during our residencies in urology. So I think when we go to a different unit, every unit has a consultant which has a special interest in one of the subspecialties. So when you are rotating in these units, I think that is the best time to reflect upon yourself and which subspecialty do you really think you want to pursue for the rest of your life. And that is where you start thinking whether you want to continue, whether you want to pursue a fellowship in this subspecialty after you complete your residency. Also, you need to focus on your long-term goals. You need to identify where you really want to stand, where do you want to really work at the end of the residency, where do you plan to settle, whether it's a metro city, it's a village, it's a tier 2 city. What are the needs of that city, and how are you going to meet the patient's need of that city? These are the questions which you should be asking yourself when you are deciding regarding the fellowship which you are planning to pursue. The other thing that you need to take into mind is the future professional trends. Every now and then there are not only technical advances, but also clinical advances that are coming up, and you need to be very aware and up to date with these things. And if you are not being exposed adequately during your residency program with those things, I think it's reasonably fair to think about a fellowship and do that. Also, most of the fellowships and scholarships are generally awarded within 5 to 10 years of passing your residency, and they prefer applicants less than 40 years of age. So these are important points where you need to actually act upon very early during your residency, so that after you complete your residency, you're immediately recruited into one of the fellowships. So this is a 10-step simple rule that was actually, it's not relevant to the fellowship setup. I'm just extrapolating it into, you can use those 10 steps into contemplating how you can go about applying for a fellowship. The first will be defining, is it worth? Do you really want to do it? Is it really worth where do you want to finally settle down? Will it really change your practice? Will it really give you an upper hand compared to the other practitioners in your vicinity? The second is identify your personal needs and expectations. Then you have to make a plan. Now, research, I'm not talking about making manuscripts and everything. This research is regarding whether if you want to do a fellowship in a particular subspecialty, you need to research in where is the best option, who are the good mentors, how can I approach them, when do I get when are the applications coming in, and how do I apply to them? So this is the research which I'm talking about in this. Then you need to invest into technology. You need to invest into technology because there are virtual meetings, presentations, and interviews there that will be conducted. So you need to have, online. You need to be acquainted with all the online interfaces of Zoom and all the other interfaces, Microsoft Teams, where the interviews are conducted. You need to have a good camera, web camera, and audio visual, so that whenever you conduct an interview, there is no disruption in the interview, so that your interview goes now very nicely. Next would be to prepare. You have to take your time and prepare for when you analyze the requirements for the fellowship at a particular center, the mentor, you need to prepare for those things. You need to build up your CV, do manuscripts, do research activity, do presentations on international levels, make it worth your while. When you're there, you should be 100% over there. You should be grasping every aspect, even clinical, ethical, all the aspects of the learning from that place should be incorporated into your practice. So just a little bit about my journey. I was in Tata Memorial. I joined as a senior resident. I was fortunate enough to see a lot of managed advanced and complicated cases. So basically, this is what I wanted to show is the experience in Tata Memorial gave me the confidence to do these independent surgeries, do these major surgeries independently. And this is why I favor that in the long term, a long-term fellowship will diversify your skill sets outside of the graduate work. It fills in the gap of your technical knowledge, provides you time to refine your research goals. It pairs you with an expert in your field of choice in order to pursue research, improves your technical and soft skill, expands your publication records, and adds experience to your resume, and expands your professional network. Thank you.
Thank you so much, Deep. It was a fantastic talk. Can Mukhilesh join us for his talk on favoring short-term and focused fellowship? Over to you, Mukhilesh.
So good evening, everyone. I would like to thank USA and you for giving me this opportunity to basically share my experience of my short-term fellowship. So I'm Dr. Mukhilesh and I have completed my focused fellowship in endourology, which was basically short-term. So compared to 2000 and now in 2020, why do we need a fellowship? So most of us here and know that our professors, they never had the fancy terms behind their fancy degrees behind their name. Probably the only fellowship we will be knowing is FRCS, that is was only fellowship available that time. But 20 years down the lane, we see lots of fellowship in endourology, transplantation, and whatnot, pediatric urology, everything is under fellowship. And even the fellowship centers have started to grow. So why do we need fellowship? Basically, there is a disproportionate increase in the seats. For example, where there was a 2 PGs per annum intake, now it has become 6 to 7 PGs, and the cases hands-on started to decrease. And there is execution of bonds. Basically, in a government setup or government medical colleges, where whenever the PGs finish their residency program, they have to execute the bonds. And if those PGs are posted in a government medical colleges, they will be trying to grab the chances. So the residents will be the sufferers. And government colleges, what happens over there? There are promotions occurring in, and transfers occurring in a regular basis. So whenever a junior most person becomes an assistant professor, he will again come and grab your chances depending upon your chief's discretion. And yojanas, obviously yojanas also come here because because of the increase in yojanas, the cases which were initially operated in the government medical colleges are getting 3-star and 5-star treatment in a private medical colleges. So why should they come to government medical colleges? Again, the caseload starts decreasing. So all these things, the PG suffers, the cases which were easily operated prior years by the PGs, like nowadays they don't even get a chance. So again, Corona also comes here. There was a saying like the particular batch in the 2020 and 2021, they were called as COVID batches because like they were much more trained in treating COVID than doing a PCNLs and the ureteroscopes. So USA members, like it has drastically increased, like from 1750, this was in 2008 data, now it has become a 3142, double in just a span of 10 years. So number of urologists coming out has increased. So, and this number of urologists are settling predominantly in the cities. All major cities has got at least 200 urologists per se. And how does we stand out among the crowd of 200 urologists? You need something behind your name so that the corporate picks you up, or like you stand out from the other group of people. So fellowship has become essential nowadays. But as my friend Dr. Deepak Jain was saying, getting a fellowship was not easy. Like after spending about 16-17 years, like it is not so easy to get again to start reading from the day one. So basically the fellowships available are like endourology. In India, like right now endourology is like obviously from the beginning is one of the bread and butter for all of us. And endourology fellowships are pretty much available in India right now. And the famous one is like Lakeshore Fellowship, where they combine laparoscopy along with the endourology. That's for 6 months. And Preeti Urology Hospital gives a fellowship for 6 months. And Dr. Madhusudan Agarwal in Agra, he also gives a fellowship for endourology of 6 months. And laparoscopy and Lakeshore, I was saying earlier. Reconstructive urology, Dr. Kulkarni sir, he gives a fellowship for about 1 year. And andrology, there is no structured fellowship right now available in India. We need to go to either to US or Europe. And uro-oncology, there are a couple of 3-4 centers where we get a fellowship program. Urogynecology, there is a fellowship program, but predominantly it is awarded to gynecologists. And transplantation, it is under the name of transplantation for solid organs. Like even the kidney transplantation fellowship is available. So predominantly it is solid organ transplantation, and it is also been given to the person who finished MS, need not be an MCH candidate. And pediatric urology, there are no takers for a pediatric urology fellowship, and sometimes it is being awarded to the pediatric surgeon just to fill up the seats. So what happens after MBBS? Like this like meme, like when between this, among these two things, like one car is owned by a doctor. So obviously all of us will be knowing which one the car, because like once we finished MBBS, this will be the state nowadays, because the salary which we get after MBBS is pretty much peanuts. So we keep on studying throughout the life, and like when we start after MBBS, MS, MCH, then you start reading again during your fellowship program. Your kid will come and sit next to you, and he will be asking you to teach you alphabets. So this will be the thing if you do a long-term fellowship program for 1 to 2 years. So what happens? Minimum it takes 17 years. Like 17 years. Sometimes it may go up to 20 years. Nowadays, exit exams are coming up for every stage. So if you're not able to clear those exit exams, then again a year or two will be missed up. So it takes minimum 17 years to settle or like to earn properly in our life. And you can't just start earning immediately when you're going to start your practice. So it will take another 3 to 4 years to build up your patient trust. The patient has to come to you and all those things. It's a pretty complicated process. So what started like when you are doing a first year medical students, you will lose your entire youth in your studies, and like we know like our youth of like our time period of earning starts after 33 years, and like before 50 years we have to earn. And in the morning talk, like the cardiologist was saying, like our lifespan is reduced by 1 decade. So we have to earn, we have to enjoy, we have to do everything before 65 or 70 years. So we can't keep on spending 2 years, 3 years in a fellowship program. So just because like fellowship program, I mean like you have to cut short, doesn't mean that you have to compromise on learning curve. What does the literature say? So if you want to do a PCNL, the PCNL case, like you can reach standard plateau after 60 cases, provided like 60 cases in a high volume center, you can achieve in 3 to 4 months, not a big deal. So 60 cases is what the literature says for the PCNL. And for laparoscopic nephrectomy, they say like 22 is the learning curve cases. And for whole up, it is about 40-60 cases. So when you are choosing a fellowship program with a proper, under a proper mentorship and a proper training center, and these numbers can be achieved immediately. You don't require 2 years to spend to learn an endourology program. You can finish off in 3 to 6 months. And even erythroplasty is like provider, like you can understand easily basic things. Like it is not that like the entire fellowship will be spoon fed to you. You will be learning even the basic cases, like that the confidence you have to develop. Like after that you come out and practice yourself. So financial stability is again the basic thing which we have to take into consideration. As Dr. Deepak Jain was saying, like it is not easy to have an EUA membership, because like EUA membership, you have to renew it annually. So if you are going to renew it annually, like you have to keep on spending amount for that. And if you're not getting fellowship in the next 3 years, like if you're going to wait 10 years, like 10 years, you have to keep on renewing the EUA amount. And the fellowship programs do cost you. If you want to get out from India, like you have to shift your families, and shifting a family for a 2-year period, and like you have to think of everything over there. And the stipend again provide depends upon the institution where we go. Not necessarily like all of them will be providing a stipend. Some centers like there won't be any stipend. Sometimes we have to compromise on that. So financial stability is a greater thing to be considered, especially after MCH, like where we won't be having much savings, and there will be a family to take care of it. A couple of kids will be there. And if it's going to be a long-term fellowship, you have to consider the logistic of shifting your family over there. So all these things have to be considered. So again, I'm using this slide here. Like, so if you're doing it, like if you're doing a fellowship program, like you have to consider whether we need a fellowship, because like not necessarily if you're going to settle in a tier 2 or tier 3 city, and if you're going to do an robotic fellowship just because you got it, I don't think it will be a ideal thing, because like finding a robotic center, even a tier 2 city, is a difficult thing. But being a neurologist, the advantage of practicing a specialty in a tier 3 city is one of the wonderful thing to happen, because neither of the other specialty department like neurosurgery or a cardiothoracic surgery can never be practiced in a tier 3 city, because like you need a team of doctors, you need a very good ICU setup, everything has to be there. So that advantage of urology can be utilized, provided if your town is a tier 3 city, and you can plan on a structured short-term fellowship. Like you just have to learn a PCNL, you come back and do. I just shared my personal experience and finished off. This was me in the 2017, and my town is a small town of about 4 lakh population, and I was in the crossroads what to do. I was like not confident in doing a PCNL, because like I didn't have much exposure. My dear senior Dr. Karthikeyan sir guided me, and like I joined Madhusudan Agarwal for the PCNL program over there. That was an informal program where I went in 2017. I spent about 4 months over there, and like right now I'm doing PCNLs, mini perks, everything. And so it is family is also much more important, because like when you are in the prime 35, 36, your kid will be in the 1 or 2 years. Like you don't want to miss his birthday. You don't want him seeing, coming to you, kissing you, and all those things you'll be missing. By the time you finish off a fellowship and go, like he'll be big, and he might ask you who you are. So family is always important. So learning never ends. Like just because like we have finished MCH, we continuously keep on learning. Learning never ends. Like there is no stop for learning. And so size doesn't matter, and skills do. Just because you do a 2 years fellowship doesn't mean like you have to have a adequate skill. And you do 6 months program, and you can have developed skills. So short-term fellowships are the way to go in the future. Thank you.
I thought this was a crossfire, but both of this fellow, my friends, they were firing from the same, kind of one side of wall, and that wall was USI and Ministry of Health and Welfare. Because they were talking more about the lengthy kind of studentship which we encounter into that. Yeah. So anyway, so your points are well taken. Anyway, USI is into frame of mind. They are already starting their homework, and they are now getting into this USI affiliated fellowships, by the short term or long term. So let's look forward where they go. So again, coming back to the journey, 17 years, not our friends. Our friends start earning, start getting married, start getting children. Even we start getting married, because if we wait for 17 years, no one will marry us. So my kid was, appearing for his first standard exam when I was appearing for my DMB exam. So that's all right. So that's what we need to bring into notice of Lakshman sir and Keshav. So we started in this journey, and then we all know our president came in between that journey. So now there are two options. Either there is a short-term fellowship which can make you, something like very talaiva kind of thing, and then there is a long structured, and then tab tak to sir budde ho jayenge. So that is the one thing which we all need to figure it out and see. Yeah, but that should not be happen that, after doing MS general surgery, if you say by 22 cases you learn laparoscopy and nephrectomy, a surgeon goes to some center, does 22 cases and becomes a laparoscopic surgeon. So we don't want that. So we need to have the structured program, but then we need to consider that thing also. So that's what is there. But, as in PCNL, we have PCNL, we have mini PCNL, we have ultra mini PCNL. Same thing. We had 1 to 2 years structured fellowships. We had 6 months focus fellowship. So we had something to offer for a 2 days of kind of, enhancement program in our center. So I would welcome each one of you. You can come down and get benefit out of this. Thank you so much. And it was really fantastic session. Before we end, Said, I need you to give one brief comment where you will put your money after spending 15 long years in becoming a urologist, a structured long-term fellowship for 2 years, or a focus short-term fellowship for 6 months.
Well, thank you very much. And I always say that the fellowship is the gate of your professional career. And if you want to do something good, it takes time. So I believe in a structured fellowship, because the fellowship is not only about surgical operation, it's about being with your mentor. It's a mentorship. You're seeing the failure stories, you see success stories, you are happy with him, you participate in everything, and 6 months is not enough. You have to spend at least, we call fellowship by years. I believe these small courses built for make a connection between congresses and countries rather than the helping building a good urologist. Invest in your fellowship by years, it will repay you at the end of your career. Thank you.
Thank you so much for that comment, Said. Thank you, Pankaj. Thank you, Said. And thank you all four of our debaters. Thank you so much, gentlemen and ladies, if they are there. Thank you. Yeah, next session, I need to welcome Prashant to take over for the reconstructive urology section. Over to you, Prashant.
Good evening. After these two heated crossfires, let us move on to next session as we are short of time. Reconstructive urology. I invite chairpersons for the session, Dr. Sanjay Kulkarni, Dr. Keshav Murthy, and Dr. Anil Elhans. And to start with, I will ask Dr. Vijay Madhuri to start his presentation.
Good evening, respected chairpersons. Good evening, audience. So as Dr. Rohit Joshi said, after the monologues and the dialogues come the video presentations, and I hope to keep it less boring and within time. I'm Dr. Vijay Madhuri. So before going on to the video, just a few, like a primer sort of a thing. Why do we need a flap in pyeloplasty at all? We all are being well served by the Anderson Hines dismembered pyeloplasty, so now why the flap? Well, it turns out in some situations, knowing how to do a flap can be really useful. One of is the long segment narrowing. This is also not very uncommon. At the PUJ level, you also find that the upper part of the ureter is also slightly atonic. You want to remove it, and you don't want to create too long a defect, which you will find difficulty in bridging. Then the intrarenal pelvis, obviously, it's difficult once you transect a part of the ureter. It may be difficult to bring the ends together again. Redo pyeloplasty, yes, because of the previous dissection and the surgery, it may be difficult and in fact unadvisable to mobilize the pelvis and ureter all around and compromise its blood supply. And in the malrotated and the ectopic kidneys also, because of the peculiar lie of the pelvis and the ureters, you may not be able to do a AH dismembered pyeloplasty very nicely. In fact, there may be some advantages in some cases of doing flaps. The first is the better blood supply to the ureter and the pelviureteric junction. And this is especially true in case of redo cases where circumferential mobilization may jeopardize the blood supply. And plus it is technically simpler as well. So we all know this type of flaps, the Foley VY-plasty, which can be anteromedial and the posteromedial as well. The Culp deviate spiral flap and the Scardino Prince vertical flap. I'll be showing video demonstrations which we do here of the Foley VY-plasty and the Scardino Prince vertical flap at our institute. So the Foley VY-plasty, we all know this is the figure from Campbell. Just to re-emphasize, this is the V and this is the stem. So this is the Y actually. These are the two limbs of the Y. This is the apex of the Y. And this configuration is in the open where you can take a lateral flap of the pelvis. In laparoscopy, we'll do it a little differently. So this is one video of a small child, 5 months, pyeloplasty being done on the right side. As you can see, this is an intrarenal pelvis. The kidney is falling all over it. And we need a third instrument to keep it retracted so that we can work. And you see, this is the retractor coming. And once this is in place, we'll get a good unobstructed view of the pelvis. And once this is done, we create the flap on the pelvis. So this is the incision which we make. The two limbs of the V, this is the apex of the both the short limbs, and one limb goes laterally and one limb comes medially. And from the apex, this is the spatulation which goes down. So you can see the lap pyeloplasty, the flap is anteromedial in configuration. So now this is an advancement flap. The pelvic flap is now advanced into the spatulation of the ureter. And then the one wall is completed and a stent is placed, and then the next wall is completed. So this is the end result after the pyeloplasty. You can see we have avoided Anderson-Heinz pyeloplasty in what could have been a difficult scenario. So again, this is the left side kind of a recapitulation, but also shows the important differences. It's different in the right and the left side because now the right side is the working port in the left. And you can see here, there was some concern here that the ureter was very taut before beginning the pyeloplasty, and hence we opted for a Anderson-Heinz pyeloplasty. The same principle again applied. The two limbs are created of the Y. And this is the limb going to one side and this is going to the other. So again, this configuration is anteromedial. So once this flap is nicely created, we go on and spatulate the ureter here onto the, starting from the apex of the both short limbs of the Y. So here you see the instrument exchange has to be done for the correct alignment. The scissor which was initially in the right hand has to be changed into the left hand so that proper orientation and proper angle of entry of the scissor can be accomplished. The two short limbs which make up the flap, now they are advanced into the spatulation of the ureter, forming the V. So this is the Y flap which converts into the V flap. This is the YV plasty. It's done over a DJ stent. We place the DJ stent for 4 weeks and then remove it. This is the end result. So, and now coming on to the posterolateral Y flap. So sometimes in laparoscopy, the configuration and the port position is such that a straightforward anterolateral flap may not be sufficient. So that's why a slightly different configuration of the pelvic flap has to be used. This is a case where we had previously stented this patient for a rising creatinine, and he has some secondary stones as well along with the PUG obstruction. So once the pyeloplasty is done, you can see the stent, and the stones will be removed subsequently. Yeah, the stones are now coming into view. Once the stones are removed, we start spatulating the ureter, and you can see now there is difficulty because of the angle of the port and plus the surrounding fat. We are not able to direct the scissor at a good angle into the ureter. So we'll exchange the instrument and also slightly reorient the spatulation of the ureter so that it goes into a slightly posterolateral direction so that the flap which was made in the pelvis may go and sit comfortably. We use 40 absorbable polygalactin sutures, and this is the flap which is being advanced into the ureteric spatulation. And once the wall is done, it's the stent is replaced and the other wall is done. So then I'm going to show the video demonstration of the vertical flap also. Briefly, this is the configuration. The vertical flap is done where you have a good ballooned out pelvis and the ureter comes and attaches at the edge of the box shaped pelvis. So this is like a trapdoor kind of a flap which comes down and the posterior wall is sutured to the spatulation of the ureter. So this is one case in the ectopic kidney, which had stones as well as a PUJ obstruction. So you can see this is a nicely ballooned out pelvis, which is facing anteriorly and amenable for laparoscopic procedure. You see these iliac vessels, it is sitting at the pelvic brim. And once the flap is delineated and the ureter is identified, a pilotomy is done. We use monopolar energy in the right hand side with the occasional cautery, and the PUJ from the inside is identified and the flap is further developed. There are few small secondary stones which come into view and which are carefully extracted out. It's important to realize that once the pelvis is decompressed, the orientation may change. Hence, you have to continuously realign yourself and make sure that the flap which you are doing is in the correct alignment. You see this trapdoor like flap which has now been created and it falls down or inferiorly, and the spatulation in the ureter is continued inferiorly and the flap goes and sits beside the spatulated ureter. So now the posterior wall is anastomosed much like the posterior anastomosis which we do in a continent diversion. So the posterior wall is finished. We don't mind the suture knot coming inside the pelvis as it is an absorbable suture. So once the one wall is done, a stent is placed and then the anterior wall is completed. So this is the video demonstration. The take home message is that we should be well versed in at least one kind of a flap because it may be required in some various unusual scenarios, and results are similar to the standard dismembered pyeloplasty. Thank you all for your attention.
Vijay, at times when you advance the short flap to the,
Yes,
so there's like buckling of the, it seems very tight. How do you compensate for that?
Sir, usually the renal descensus will help, sir, if there is quite a bit of buckling. Else, we...
No, but here the stretch is on the pelvic part.
Yes.
I mean, even if you
Yes.
mobilize
So,
the kidney,
what
that
we-
stretch
what-
doesn't reduce.
Yeah, so sometimes we don't begin at the apex. Sometimes we don't begin at the apex of the flap and we start from one end of the wall so that the lax is taken up and the apex suture doesn't tear through.
So that's the reason you require to do these flaps only when it's indicated to do it.
Yes, sir.
Otherwise, you'll find it difficult to do in all the cases.
Yes, sir.
If
So it's
it's a
not
high
indicated from
insertion,
this.
you have the pelvis, which is redundant, which you can use to do the flaps, or a long segment structure, which you showed, you can get those pelvis to come down.
Yes, sir.
So if it's a very small pelvis, it's difficult to do these flaps.
Yeah. Yes.
Thank you, Vijay.
Yeah, thanks.
I'll call upon Dr. Pankaj Joshi about flaps in urethroplasty. We recently saw Pankaj doing a good flap at Ahmedabad workshop.
Greetings, sir. Thanks a lot for the compliment and greetings to the chairperson. Hello to everyone and thank you to the organizers of the Youth Conclave for giving me this opportunity to present from the Kulkarni Institute on what are the common flaps in urethral reconstruction. Can I have my slides? Yeah, so flaps can be a part of two situations. One, it can be a part of urethral reconstruction, or second, after you reconstruct the urethra, it can also be a part of an interposition. So we know various flaps, but I would just enumerate the common ones. We have the Orandi, the pedicle prepucial tube, we have the Q flap. In the perineum, we can use the perineal skin such as the scrotal flap, Singapore flap. Intestine is a fancy flap, but a very complex surgery. And when it comes to interposition, we have the gracilis, and in our Kulkarni Institute, we have invented a technique where laparoscopically we take the omentum without doing a transpubic into the perineum by using the space in the retropubic region. But I think we owe a lot to Professor Hari Asopa because it all started in 1971 when he described the pedicle prepucial tube. And we are using it day in and out, more so now when we have started getting complex surgeries. Can you just play the video? Yeah. So this is a patient who's 27, very young, had a road traffic accident, 5 failed prior urethroplasties. He had an anterolateral thigh flap based on the femoral artery. Someone had tried a radial forearm flap. So he had 2 flaps with both femoral arteries and veins used. And still he had a long gap in the urethra. But I think what's most common there is we all in the Asian subcontinent have a prepuce, and the local flap is much more easy to do. So we've made a midline incision. There is no urethra at all. There was no previous flap tissue actually, everything had necrosed. I've done a pubectomy. We do enough pubectomies so as to access a pink supple anterior wall of the urethra. And then we start making the pedicle prepucial tube. So this involves taking the prepuce down based on its underlying dartos tissue. So I'm marking an outer circumcision incision. I'm using a knife and I'm just going to make an incision between the skin and the underlying dartos tissue. Colleagues are very important when you do flaps, and surgery works by the principle of traction and counter traction. So once I'm in the correct plane, they do 50% and the person doing the surgery below does 50%. Magnification is usually useful when we do flaps. And then we can enter a nice avascular plane, and it should not take more than about 20 minutes for us to deglove the penis. So this is an outer circumcision incision. We have to be careful here. So you can see if it's a 4K camera that we use for a recording. So we leave behind some vessels with the skin of the penis, or else after 7 days, you would see a black penile skin when the patient comes for a follow-up. That's how we avoid it. We do the dissection up to the penoscrotal junction. Similarly, till the prepubic region on the dorsal aspect. The beauty of the penis is the blood supply of the skin comes from the branch of the femoral artery as compared to that of the corporal tissues, which are the branches of the internal iliac artery. So these are the superficial branches which are very important. Now I'm making an inner circumcision incision which is deeper to the dartos tissue and over the buccal fascia. There are occasional perforator vessels which we can coagulate. If you see, the left hand is stretching the penis continuously, and that's what makes the flap dissection much more easier. In the end, what we see here is we are able to move the entire preputial skin based on its dartos tissue. As the blood supply is going to come from the dorsal aspect, I'm making a ventral incision. And then this preputial tissue can be transposed into the perineum. I once remember Dr. Kulkarni sir doing a surgery where we had taken the prepuce down, even recently, right inside the abdomen through a perineal incision. So it's very versatile. The length of the penis is equivalent to the length of the pedicle we have. Now, since we have both the inner and outer skin, the dartos is going to supply both the sides. So we can either use the inner skin or the outer skin, not both. So I'm making an incision in between the two. I may not detach it in the beginning, but we just leave it aside and then pass a 14 French silicone catheter and tubularize the urethra. We use a 5-0 polydiaxone suture. The sutures are the edges are usually interrupted just in case they give way. So we have a strength. It never so happens actually that the tube is short. We still need more length with the gaps we are getting. And then just do a running subcuticular or a subepithelial suture to make a tube. Once you are sure your tube is good, you then excise the other half of the skin. If something goes wrong, you just rotate and make a tube of the other side. If you read the original paper by John Hunter in 1941, the blood supply to the outer skin is technically more robust than the blood supply to the inner skin. And then there's a routine anastomosis that we do, that is at 11 o'clock, 1 o'clock position, 3, 9, 5 and 7 o'clock position, and then also perform a distal anastomosis. So this is how we do. We've done about 161 of them in the last 15 years, but 80% of them have happened in the last 12 years. That means what we are seeing is the complexity of the cases is increasing. And if, can you please play the next video? So if this was not enough, we still have cases where, so the girth of a penis is equivalent to the erect state is about 11 centimeters. So when you take a preputial flap, the maximum length you can get is 11 centimeters. And occasionally we have a gap where this patient had a pan-urethral stricture, absolutely no urethra, and then there's a long defect. We believe in doing a single stage reconstructions because that's how the patients travel to us. And what we have done here is dorsally, we have done a Kulkarni technique. We have inserted 2 buccal grafts. And now what I'm showing is a short clip, 2 minutes, of a Q flap, which was first described by Alan Moore in 2002. So here we are going to have a vertical limb along with the horizontal limb. This patient does not have a prepuce, so it is technically more easier. So I'm going to make a similar incision. The only challenging part is the way we dissect the dartos is slightly different as compared to a pedicle preputial tube. So it's about, that's what my guru tells me, surgery is about imagination. So doing a Q flap is little more imagining as compared to doing a circumferential pedicle preputial flap. So here, instead of doing circumferential dissection, you're going to do a lateral dissection and then go down deep to the dartos. Make the vertical incision first, and you will have a long flap up to 17 centimeters. As we have progressed, we now make a little more oval shaped flap rather than having a sharp edge at the top. Then you just disconnect the flap at the penoscrotal junction. You can see nice vessels. You transpose the flap. So the dorsal wall has the buccal graft, the ventral wall has the flap, and we are able to do a single stage reconstruction. This patient is from Uzbekistan. He had a ring stricture at the proximal area, but he's still doing so well. And now a short clip of 1 minute of an interposition flap where we walk with our colleagues. This is a patient who had a rectourethral fistula. It's a traumatic injury. So We are going to show you a short clip of a gracilis flap. We are going to dissect the fistula. We prefer closing the fistula with a non-absorbable suture and then reconstruct the anal sphincter, as this was a traumatic injury. So this is reconstruction of the external sphincter there. We have done last year, the COVID year, we had 16 of them who were referred to us actually. So this is a gracilis flap. We all know the standard marking. It has 3 pedicles. We mark 7 centimeters from the pubic tubercle and we go 4 centimeters below this line. You can make multiple small incisions or you can make one large incision about 7 centimeters. Identify the gracilis muscle. Distally, we disconnect it as far as possible to the tendon of the muscle. And the way to identify it is, it usually does not bleed when we disconnect it at the end. You pull it through the lower incision and then the first pedicle is gone. We do a gentle dissection to identify the second pedicle carefully. You can see the second pedicle here. We ligate the pedicle. And just tease the tissues down to find the proximal pedicle, which is usually 7 centimeters from the pubic tubercle. Similarly, as we say, it's the traction which helps in the surgery as compared to just the dissection. So here we can see the proximal pedicle, which is always the standard when it comes to a gracilis muscle. That anatomy does not differ in about 95% of the patient. So here we can see a nice proximal pedicle. We just swing the gracilis down into the perineum and then interpose it using the interrupted suture. So this is short about, I think flaps are more complex, but in a 10 minutes session, this is all we wanted to show that is possible, and the complexity is going to increase day by day. We heard the talk on fellowship, and what fellowship actually does in a long term is to help us do the more complex cases as compared to do a simple cases. So thank you youth organization for this opportunity, and thank you all the chairpersons and my guru for listening to me patiently. Thank you.
Thank you, Pankaj. Pankaj, are you doing more flaps now just after the COVID period, and what's the reason?
Last year, we did 56 flaps out of the 161. So actually the true number is 60% came in the last year. And the reason is many patients kept on waiting because of the COVID. And we are seeing a lot of iatrogenic injuries, complex strictures where underwent multiple dilatations, even pelvic fractures, primary bulbar necrosis, and redo failed cases. So that is the reason we have to resort to more flaps now, more in anterior urethra as compared to post. Initially, we were doing bulbar necrosis for posterior, but now we have to do for anterior urethra also.
Last question, indication of enterouretroplasty.
The only indication of enterouretroplasty is when everything fails and nothing is available. That's the only option. So in fact, we have done 5, but one of them is when one of my own pedicle preputial tube failed. So that is the only indication. It's a very challenging surgery. It is not as easy as it looks in the book, but it lasts about 6 hours, but the results are very excellent when we do it. So the world literature, I think the total number of described cases are less than 11 when you go to enterouretroplasty.
Pankaj, when you take a pedicle preputial flap down to the perineum for a bulbar necrosis, how do you ensure that the pedicle, it doesn't get twisted, because then you have to push it through the penile skin. It's a kind of a blind procedure. How do you make sure the vessels are not getting twisted, and though it might look fair at that time, but subsequently might necrose?
Actually, we can swing it from both the ways, but over a period of time, what I feel is it is just about pronation and supination of the arm. Nothing changes. Even the radial artery does not twist. So even if it just rotates it's around, the blood supply remains intact. So we have had a pedicle coming from the right side, from the left side, but the results of long term have been really good.
Thank you, Pankaj.
Thanks a lot, sir. Thank you.
Can I invite Dr. Rishi Nair to present this video on 2-stage urethroplasty?
Thank you, sir. And thank you for giving me this opportunity. These days, most of the strictures can be managed in a single stage, and you have just seen the examples by one of the experts just before me. But still, the stage urethroplasty may be required, and there is a place for stage urethroplasty, like in these cases, where particularly cases which have a multiple failed repairs or have associated diverticuli or false stack, where biphased grafts cannot be done in the same sitting. So this was one such case where there was a near complete narrowing. Even 7 French ureteroscope could not be negotiated. And subsequently, even the 6 French, in fact, 5 French ureteric catheter was also pushed with over the guide wire with the difficulty. So in this case, we decided to do a stage urethroplasty. So this is the SP scopy view. The prostatic urethra was all normal. So in the first stage, we inserted the guide wire, and then we also pushed the methylene blue, and you could see even the methylene blue could be pushed with difficulty. Just 2 ml was refluxing back. And then the access catheter was placed. The incision over the skin is marked by passing the bougie initially to mark the exact site where the stricture starts. It is essential that the skin incision matches the stricture length, because otherwise the skin puckers in, and then the chances of developing a stricture at the distal and proximal end of the open urethra are more. Because skin, once it puckers in, there are more secretions, and then there is inflammation. So after that, one has to really dissect down till the level of the urethra and isolate the urethra. The stricture is then again reconfirmed by passing the bougie. On the proximal length of the stricture may not always be feasible, because some people may use He-Grooves dilator, but that may also be traumatic sometimes. So once the urethra is open, the proximal extent would reveal itself. So therefore, we do not always use the He-Grooves dilator for the proximal extent. Once the urethral lumen proper is opened, the lumen can be followed proximally. But what is important is, as I said, that the opening of the urethra should be sufficient enough that the normal urethra must be reached till at least 1.5 centimeter on both the sides, and the skin incision should also match the exact length of the urethrotomy. After that, we do a full thickness incision on both the sides to complete the first stage of the procedure. Important thing is to maintain this urethrotomy over the period over the interim period by doing routine paraffin dressing and asking the patient to stretch out the urethra, and the Vaseline has to be applied. So only once the urethra is stable, at least for 3 to 6 months, we wait. And then at the second stage, we identify the plate, measure the dimensions, and only the urethra has to be measured. No skin should be taken for forming the urethra, no adjacent skin. The scrotal skin, as you all know, is hair bearing and will lead to complications over the long term. So whatever extra width is required, that has to be provided by the any supplementary tissue, which generally comes from the buccal mucosa. The technique of isolating the buccal graft is mostly similar. We do not use the adrenaline saline, we use plain saline only. And then based upon our dimensions that we need, the graft is harvested. So once that that is done, we'll prepare the urethral bed, and the graft has to be prepared. We also give small incisions on the graft. So the incision is given on the mucosal side of the mucosa, not including the adjacent skin at all. And then the urethra has to be completely tethered from the adjacent skin. So this is the free urethra that you can see. The graft has to be placed dorsally. So therefore, incision is given in the midline, and then a space is created for placing the graft. Important is not to undermine the edges of the urethral plate, because if we undermine it, we may end up injuring the urethral vessels itself. So therefore, the incisions are basically on the tunica albuginea to widen the incision. It is not underneath the urethra. So once that is done, the graft can be placed, starting from one side of the graft, taking full thickness sutures, along with the underlying tunica albuginea of the corpora. So after that, quilting sutures are taken. This can be done in a linear fashion, as we have learned from the master himself. He is sitting here, Dr. Kulkarni. Linear stitches, 2 or 3 rows of these stitches are taken so that the graft fits itself in the space that we have created. So once this is done, the graft seems to be forming its own tube by itself. It gets buried into the dorsal surface. So finally, the other side is also sutured in a continuous fashion. We place the catheter, and then the urethra is tubularized over the catheter. Again, important is one should check that the 2 edges of the urethra are coming easily over it. There is no tension, and if there is some, one can always mobilize more and de-tether the urethra on either side. But this tethering on the dorsal surface should be limited only to the extent required. So finally, the second stage closure is nearly complete. And over this, we'll do 2 more layers of closure. First, the bulbospongiosus muscle, if it is available, or the scarpa's fascia. And then it would be the Camper's fascia. And then subsequently, the 4th layer would be provided by the overlying skin. So this completes the 2-stage process. The catheter has to be kept a little longer in these cases because the graft is there and there are multiple suture lines. So we keep it at for nearly a month in such cases, particularly if the ureterotomy is long. So thank you very much. If there are any questions, I would be happy to answer.
Thank you, Rishi. Any questions from the audience? Pankaj, how would you treat this patient? Do you do 2-stage buccal mucosa graft urethroplasty for bulbar strictures?
Yeah, I agree, sir. Actually, in cases which have associated sinus tracts or diverticulae, the ventrum side doesn't, we can't use the graft on the ventrum side because it is an infected tissue. And either we will have to use simultaneously flap along with the graft, or it is actually ultimately ends up with as a personal choice. There are few cases where stage repair may still have a role.
Thank you, Rishi.
Thanks.
Now I call upon Dr. Abhijit Patil to talk on harvesting buccal mucosal graft.
So good afternoon, everybody. After those complex surgeries, mine is a very simple talk, and that too presenting in front of Guru is very challenging thing. But the talk today is how to harvest a buccal mucosal graft, step-by-step technique. So it was actually in 1894, Shapizo, a surgeon from Ukraine, first described a use of buccal mucosa from lip and mouth for urethral stricture diseases. In 1993, it was El Kasabi from Egypt who first described the use of buccal mucosa from lip to repair the adult patient urethral strictures. So in 1996, it was Mechanich who suggested a new technique of harvesting buccal mucosal graft and simultaneously harvesting the buccal mucosal graft and perineal and the urethroplasty in the same setting. So what are the grafts which are present for urethral substitution is a buccal mucosal graft, lingual graft, labial graft. Bladder mucosa and rectal mucosa have a lot of morbidity, so it is generally not accepted. Post-auricular skin is a very good option if you cannot take a buccal mucosal graft for any reason. Now, what are the advantages of taking a buccal mucosal graft? It is a non-hirsuate surface. It has a thick, non-keratinized epithelium, which is almost similar to urothelium. Oral mucosa possesses a very good vascular supply in the lamina propria. The tissue is also resilient and easily handled and harvested with minimal or negligible donor morbidity and no cosmetic impact on the patient. It can be taken around 5 to 7 centimeters from one side of buccal mucosa and on the other side also. So both sides can be taken. Now, which are the patients which are not actual ideal candidates for buccal mucosal graft? Are the patients who eat chew areca nut products like betel quid, pan masala, gutka, canny. They develop oral submucosal fibrosis, so that graft is difficult to uptake. Patients who chew tobacco, patients who currently have infectious disease like candida, lichen sclerosis, varicella, herpes zoster, and so on. Patients who have previous surgery in the mouth, prohibiting wide opening of the mouth. Now, what is the point to be remembered while harvesting buccal mucosal graft is that you should first mark a Stenson duct, which is a parotid duct gland opening. It is opposite to your upper second maxillary molar tooth. A minimum of 5 mm margin from the lip should be kept so that it doesn't got puckering and has an cosmetic effect. You should stay away from the masseter muscle so that if you injure the muscle, there is bleeding and also patient has post-operative pain. There is you do a hydrodissection as some have used NS, but we use adrenaline per lignocaine. So it gives slightly post-operative pain relief also and helps in dissecting the plane between the lamina propria and the muscle. We can use endonasal intubation, which I'll tell you the benefits of it. If it's a small buccal mucosal graft, you can actually suture it off. But if it is big, don't try to suture it off. It will cause more of puckering and post-operative pain. Now, the nasal intubation has some benefits that the tube is smaller and softer than your oral intubation. It is useful, especially when a limited mouth opening is there. And if you have a nasal intubation, both side buccal mucosal grafts can be harvested. Now, this is an important thing is that this is epithelium, this is lamina propria, which is actually has a blood supply and helps in uptake of the graft. This is the layer of submucosa or the fat, and this is the muscle. So this is the layer where you actually harvest the graft, and after harvesting, you do defatting. So you remove this so that your lamina propria uptake is good. Now, this is a trolley which generally is required for buccal mucosal graft. So what have you can use this mouth retractor. The benefit of his mouth retractor is that this is applied to your upper lip and this is applied to your lower lip along with a tongue depressor. Or if you don't have, you can use a deverse. What other things you are required is that this is a 10 ml of lignocaine plus adrenaline 2% with a 26 French, 26 gauge, 1.5 inches needle, which is used for hydrodistension. This is your marker, 15 number knife. This is your dolphin scissor, your scale, and this you can use wood, silicone sheet, or a thermocol, whatever is required. Then you require some 4 insulin syringe needles for meshing the graft, and a bipolar cable, bipolar cautery. So these are the steps of buccal mucosa graft harvesting. Is that first you do a nasal intubation with throat packing, so that when you clean your mouth or whatever blood or betadine goes doesn't go into your throat. Then you apply a retractor, you mark the Stensen's duct, then you mark the graft, you infiltrate, then you harvest the graft completely, then you confirm the hemostasis, and then you keep a betadine gauze. So this is the video. This is the position where both urethroplasty and buccal mucosa graft can be harvested. Your mouth can be cleaned like this with plain NS or betadine. Then we'll take a stay suture in the lip, in the lower lip, as well as in upper lip. So this helps in traction of the lips. Now the second thing that we'll do is we'll identify the Stensen's duct. So this is how you can use this reverse with the gauze and with your tongue retracted to the opposite side. You just keep it there. You have a very good vision. This is your Stensen duct opposite the second molar. You identify it, then you mark it. When you mark it, you mark. This is you have to keep at least 5 mm distance from your margin, and then you completely mark your buccal mucosal graft. So this generally depends upon the length of the graft that you require, as you know from your urethral dissection. Now next step would be to hydrodistend it. This is a 10 ml syringe with this is a 26 gauge needle with a 1.5 inch needle. So the point to be noted is that it has to be instilled in a proper layer. It should be above the muscle and below the submucosa, and you should see a blanch happening over there. If you don't see that blanch, then you have actually hydrodistended in the wrong layer. And this you have to do from this layer, this point to your all the way into inside. And this is generally, if you have a broad graft, you have to repeat it in layers. So as you can see, that is why I have not edited this part. I've kept it this way only, so that you can see the blanching of the graft. If this is correct, then your harvest is very easy. Then you use a 15 number knife to mark along your marking, cut along your marking. Should be a superficial cut. Now next thing that we'll do is we'll take stay suture at the angle of this graft. And this we will give to the assistant. The benefit of this is that you can give a contraction traction with these sutures, and you can give contraction with your left thumb. So your initial cut should be in the proper plane. Your first cuts are very important, and then they determine your layer of your harvesting. Further, proximal cuts are easy to be taken. Your distal cuts are difficult to be taken. So you can see, you can counter traction can be given with your left thumb with a gauze, and this two counter sutures can give a good traction by the assistant, and he will take it to his side, and at the same time you will take your lip to your side. So as you can see, this is the muscle method, and you try to be above the muscle. As you can see, this is the muscle, and you have to cut above the muscle. Don't let the muscle be on the graft. And mind you, if you are in the correct plane, you will have minimum bleeding. And slowly with traction, counter traction, you can slowly enter this proper plane and lift up the graft.
Abhijit, time.
Yes, sir. It's finished. So this is your final graft, and then you can take your 15 number knife and you can just cut the graft at the most proximal position. what is important is the defatting of the graft. So there are various ways of defatting the graft. I generally prefer it on my finger so that I come to know how deep am I doing the defatting with my scissor. So this should not be either thick or thin. If it is too thin, then it will got contracture. So point or tip is that it should look whitish or yellowish when you defat this graft. Then we use a thermocol and 4 insulin needles, give it a proper traction, and then we can mesh the graft. So meshing widens the graft and give at least 1 centimeter of length to the graft. So we'll take a 11 number stab knife, and it should not be vertical, it should be slightly. So when you insert it slightly, it gives you a good incision on the graft and meshing. That we should do in a parallel manner. After this is done, you can see how how well the graft is taken up. So hemostasis is achieved and you can keep a betadine gauze. So this is how you can take at least a 7 centimeter of graft from one side. And if you take 2 grafts, you can have the complete urethra from the distal urethra to the proximal bulbar urethra. And what do we do is that post-operative, we ask the patient to have cold fermentation. We ask them initially first day to have cold and non-spicy food. We give the patient anti-inflammatory and continue chlorhexidine mouthwashes and ask him to puff his face so that he doesn't develop contraction. Thank you.
Thank you, Abhijit. Now I call upon Dr. Utsav Shah to present his video on perineal ureterostomy.
Good evening, everyone. Greetings from Ahmedabad. I would like to thank the Youth USI and the Council for giving me this opportunity. My topic is perineal ureterostomy. And can you restart it, please? Yeah. Please play. So the indications would be a lengthy stricture, hypospadias cripple, previously failed surgery, and a patient who does not wish to have multiple surgeries and is fine with exit of urine and semen from the perineum. A lithotomy position is fine. In this particular patient, a long anterior stricture was there with changes of BXO, as we can note here. The guide wire could not be passed. The first step would be to make an inverted U incision to expose the bulbar urethra. The landmarks for this would be between the 2 ischial tuberosities, which in a way such that the apex is at the root of the scrotum. Using a monopolar cautery, this space is developed. It is important to create a full thickness flap in order to have full thickness advancement flap in order to have good vascularity and to avoid necrosis of this flap. Using sharp dissection, we then go ahead and cut the bulbospongiasis muscle. It is important to note that the exposure should be adequate, and here you can see the glistening layer, which is the urethra and is
coming into picture. Following this, a retractor is placed. Generally, a mastoid retractor can be used, and this can be accompanied with the lodestar perineal retractor. Better space is created, more space is created in the periurethral area, and the urethra is mobilized, not fully, but enough to, and then it is important to identify the urethra. In this particular case, a bougie was passed, since there was an SPC tract, a bougie was passed. And it is important to not imagine, but to prove that this is actually the urethra, or else we can easily do it, anastomose in a false passage. So this is the sound, which is bougie that is coming from the SPC tract, and it is open longitudinally. A gorge is then, it is optional. You can use it for better vision. Then you should trim the advancement flap, mature the advancement flap. Here, 3 stitches are passed through the apex of the scrotal flap. So here the stay sutures are placed, as you can see over here. It's not, yeah. So these are the stay sutures placed, and suturing is commenced by taking sutures from the scrotal flap. Over here, the needle is placed in this way so that it goes in directly. This is particularly the way which is used in this Webster's progressive perineal urethroplasty. So it is placed in, so the needle goes in from here. You have to push it in, and then it comes out. This is just a representative diagram from Dr. Kulkarni sir's book, which is the Atlas on Urethral Reconstruction. The 3 stitches are passed through the scrotal flap, are pulled, and then re-approximated with the urethra. So you pass the 3 stitches from the scrotal flap into the urethra, and then you pull them, and so they get approximated. And then you take the stitches. So this is the urethra. These are and you further, the further scrotal skin is further approximated to the ureterostomy. Vicryl suture is used. In this particular case, a rapid vicryl with a cutting needle was used. So the flaps are then, the scrotal skin is then anastomosed all along. And you can see that there are certain stitches that are taken so that first the urethra is, as you would see here, the urethra will be taken to so this stitch is passed through the urethra and with the corpus. So corpus spongiosum, so that it bleeds less. And once this is done, then the superior skin is sutured. Closure is done with absorbable sutures, and the catheter is placed. This catheter is placed for 3 weeks. So we all need to love our perineum. So this particular recording was done in the Penricon workshop a few years back. And we recently concluded the 4th edition of this workshop, and all patients are doing well. Thank you so much.
Thank you, Utsav. Very nice video. I just want to make a comment that in our unit, we perform about 500 uretroplasties per year, but we hardly do perineal urethrostomy. There are few reasons for this. First, as you grow older, your knees start hurting. To pass urine, you have to sit down. Then a male can pass urine by the roadside, but here he has to pull his trouser down to pass urine. And lastly, because perineal urethrostomy, it's not a vertical slit, and the spray will wet the feet. You understand? So in our unit, we do perineal urethrostomy only for amputation penis patients. So very, very rare. This is personal opinion, but the books say that it should be done in old people. I always used to say that our Dr. S. L. Bapat, who was 85, do you think he was old? No, he wouldn't accept a perineal urethrostomy. You agree with me? So this is a personal opinion.
Thank you.
Thank you, sir.
We move on to the last paper, Ileal ureter by Dr. Sitaram.
Good evening, everyone. I'm Dr. Sitaram. I'm here to present a video on ileal ureter. And I thank the chairpersons, USI and YOU for giving me this opportunity. And I presume everybody must be looking forward this talk, as this is the last one for this day. So, long obliterative, bilateral, proximal, and radiated ureter strictures. These are usually complex by definition, and also complex for a young urologist like me to treat. And long complex strictures affects the quality of life and renal function of the patient. The most common causes are iatrogenic injury, that is endourological procedures, gynec and oncological surgeries, radiation, stone disease, trauma, RPF, and tuberculosis. So we have so many options to treat the ureteral strictures. We have psoriasis, Bovary flap, we have transureteral ureterostomy. But still, there are complex strictures where you need to look for other options. And one of the strongest weapon in the armamentarium will be using a ilium as a substitution for the stricture ureter. So we can use an isoperistaltic segment of long ilium, or we can use an Ang-Monty technique of reconstruction using shorter segments to create a long length of defects. So here we are going to demonstrate a cat-tail ureteric reconstruction for bilateral long segment ureteric strictures, step-by-step demonstration.
This is our index patient who has a left upper ureteric and right mid ureteric stricture requiring bilateral ureteric reconstruction. So we perform an AGP and RGP to confirm the site and size of the stricture on both the sides. This is the end goal that we would like to achieve, whereby we anastomose the proximal end of the isolated bowel segment in an end-to-end fashion to the upper ureter on the left side, and we anastomose the right mid ureter to the end to side fashion of the bowel towards the distal end, and the distalmost end goes into the bladder. We perform an infraumbilical midline vertical incision, and the abdomen is opened in the midline. We take our attention towards the right side, where as expected we find the ureter adherent to the surroundings. We identify the ureter with blunt and sharp dissection. Once we are able to identify the ureter as seen here, we sling the ureter. Care is taken to not hamper the vascularity of the ureter, at least in the proximal segment, which is the better segment. Once the ureter is slinged, we move our attention towards the left side. On the left side, exposure is difficult since the stricture is quite high. We perform similar blunt and sharp dissection on this side. We use a light cable for better vision. Here, the ureter is traced right up to the left renal pelvis. Once the ureter is identified, as seen on the right side, we sling the ureter. Once the ureter is slinged, we identify the deceased and the non-deceased segment. So then we isolate the segment of bowel that we wish to anastomose. This is 15 to 20 centimeters proximal to the ileocecal junction, and 15 to 20 centimeter length of the bowel is taken. We take marking sutures, leaving the long end towards the proximal side and the short end towards the distal side. We then draw out the Foley catheter and fill the bladder. This is done so that we are able to ensure a tension-free anastomosis of the distal end to the bladder to see if the segment of ileum is coming down without any tension from the left renal pelvis right up to the bladder. Once adequate length of the bowel is confirmed, the bowel segment is isolated after opening up the mesentery and using ligashore. This prevents any significant bleeding. Once the bowel loops are isolated, the rest of the bowel, the continuity is restored in a double layered bowel anastomosis, that is the ileal anastomosis. We close the mesentery to prevent any herniation of the tissue, and a wash is given to the isolated bowel segment to free it of any bowel content. The proximal bowel segment is passed under the sigmoid mesentery towards the left side, and a guide wire is passed through the bowel loop that will enable us to pass the DJ stents. The left ureter is first spatulated. After the spatulation, an end-to-end left ureteroileal anastomosis is performed. This anastomosis is performed using 4-0 vicryl sutures. A tension-free, watertight anastomosis is achieved. First, the posterior layer, followed by the anterior layer. As one can see, the anastomosis is almost close to the pelvis on the left side. This is the final result. Right side, an end-to-side right ureteroileal anastomosis is performed. We make an enterotomy, after which we spatulate the ureter of the right side. Again, 4-0 vicryl sutures are used, and the anastomosis is completed in a 2-layer method. The anastomosis is a Bricker type of ureteroileal anastomosis. Care is taken not to handle the ureteric mucosa too much, and a DJ stent is passed through the right ureteroileal anastomosis. After the DJ stent placement, completion of the right ureteroileal anastomosis is performed. We then fill the bladder and bring the distalmost end of the bowel to the bladder and make a vesicostomy right at the dome of the bladder. An end-to-end anastomosis is performed between the ileum and the bladder. Care is taken to include the mucosa on both the sides. 3-0 vicryl suture is used to perform this anastomosis. Once the anastomosis is complete, the patency of this anastomosis is checked by filling up the bladder. Subsequently, the omentum is placed over the right ureteroileal as well as the ileovesical anastomosis to bolster the vascularity of the same. This is the end result as we had demonstrated. We have performed an end-to-end ureteroileal anastomosis on the left side. An isobaristatic bowel segment is brought down to the bladder, and along the way, a right end-to-side anastomosis is performed with the right ureter. This is the post-operative X-ray.
Yeah, my colleague's voice sounds better than me, so I kept the one in the video.
This is our index.
So this patient was doing well at a medium-term follow-up at 11 months. The USI, in the ultrasound, there is no HUN. Creatinine is well, maintaining at 1.2, and the ABG is not showing any hyperchloremic acidosis. And coming to the long-term results for the ileal ureter, the largest reported series published by Armetis et al. There is a 91 patients included. The anastomotic stricture rate was 3.3%, fistula is 6.6. And as we all worry about the renal function and failure in the long term, the creatinine remains stable or decreased in majority of the patients at 74%. And the hyperchloremic acidosis is only 3.2%, which are managed with substitution with the sepsis. So conclusion, ileal segment for ureteral reconstruction is safe and feasible option. It is effective in preservation of renal function and provides a good conduit for dryness. Thank you.
Thank you, Dr. Sitaraman. Any questions from the floor? Thank you.
Thank you.
So So we have finished on time. So over.
Yeah. Thank you. Thank you. I would like to thank all the participants and the chairpersons for this session, Dr. Sanjay Kulkarni sir, Keshumurthy sir, and Anil sir. Now, for further announcements, I hand over to Zishan.
Thank you, Dr. Prashant, and thanks to all the chairpersons, and thanks to the crowd for being here. We have a dinner organized at Radisson Blu High Tech City at sharp 7 p.m. So there will be a lot of traffic. So what we thought was, we'll go directly from here to High Tech City. That's Radisson Blu. Take all your cabs and make sure that you're there at 7 p.m. sharp. And thank you all for coming. Tomorrow we'll be starting at 9 o'clock sharp. So I request all the YOU board members to come on stage.
Now.